already there. Dr. Sridhar, are you online?
Can you guys hear me?
Yes, sir, we can hear you.
Okay, thank you. Do I have privileges to share my screen here somewhere?
Oh, yeah.
Yes,
Can you
of
just
course.
share and I see that I didn't
Hi, Sri.
recognize you. Yeah, good to see you.
Yes.
So, can you just share once? Yeah, it would be better.
I just wanted to share the screen so that we know it works.
Yeah, yeah. Hi, Rajkumar.
Hello.
So, can you do that? Can you share it?
Yeah, I can. Yeah, I can.
Yeah.
Hello, Magesh.
You can see my screen.
Yeah, yeah.
Sorry, I was on mute.
Yeah, I know.
Dr. Sridhar, we can see your presentation very well. Not an issue.
All right, thank you.
Yeah. So we still have 1 minute to go. Yes.
So Rajkumar, good to see you.
Yes, Magesh, you are
Started
busy.
elective कि नहीं अभी?
No, elective, yes, we have started full-fledged.
I guess we're live now, so.
Yeah.
Is
Let's
it?
start. Yes. So good morning, everyone. I am Dr. Srinivas Kasha, Secretary to Twin Cities Orthopedic Society, with our President, Dr. Somashekar Reddy Garu. Welcome you all to this total hip arthroplasty. So this program is being conducted by Twin Cities Orthopedic Society under the aegis of TOSA, Telangana Orthopedic Surgeons Association, and it's supported by Janssen's. And before we start, last week we have lost a great man and best human being and top academician, Professor B.P. Narasimhu Garu. At 90 years of age, he was an active Twin Cities Orthopedic Society member. And in respects to his soul, let us all show our respects by paying silence for 1 minute time. Okay. Can you hear me? Yeah. So let me introduce our galaxy of faculty today. Dr. Sridhar R. Rachala. He is lower limb replacement surgeon at University at Buffalo, and he is going to share his experience with us in today's webinar. We have a national faculty, Dr. Mahesh Kulkarni from Pune, joint replacement surgeon, very well known figure, and Dr. Rajkumar from Ganga Hospital. We have got Dr. Krishnakiran Ichampati from Hyderabad, Dr. Ashok Raju from Sunshine Hospitals, Hyderabad, Dr. Mithinachi from Apollo Hospitals, Secunderabad, Dr. Satish Reddy from Prime Hospital, and Dr. Somashekar Reddy. So, without any delay, let us move on with our first talk by Dr. Mithin, evolution of hip arthroplasty. I'm just stopping sharing. Mithin, can you please start sharing your screen?
Yeah.
Yeah.
Is that fine?
Yeah.
Okay. Thank you, Dr. Srinivas, Dr. Somsar, and TCOS for this opportunity. I've been asked to talk about evolution of hip arthroplasty. So in my preparation of the slide, I understood that the more you know about the past, the better prepared you are for the future. So that is why it's very important for us to know about our history of how exactly the profession that we are in, the implants that we are using, how they have evolved over a period of time. So obviously everyone knows that it is Professor Themistocles Gluck, German doctor, who's debated to be the first arthroplasty surgeon in history. He actually replaced joints destroyed by tuberculosis with ivory hinged processes in about 1890s. He presented it in a German scientific conference. This is his original drawings. You can see that there is a hinged processes and it was made of ivory. And the beauty is he has actually replaced almost all joints, all major joints of the human body during that time, even though he's known more for the hip joints. He has used joint replacements in almost all parts. But the lessons he learned when his when his joint started to fail was pain relief is immediate with this joint replacement that he did. Good mobility is achieved, but joint replacement fails because it was done in the presence of infection. So this is one of the lessons that we have to take from the story of Professor Gluck. The next doctor is Dr. William Baer, who actually made this interpositional arthroplasty, which was having on and off procedures being done in different parts of the world famous. So his interpositional arthroplasty used pig's bladder, facial lata, etc. in patients. And the lessons that we learned from William Baer's experiences, there is a high failure rate due to biomechanics as the hip started to fail, and also infection rate. It was Marius Smith-Peterson, Dr. Marius Smith-Peterson in 1920 to 1940s, who used the different types of materials as mold arthroplasty. He used initially glass, then he went to Bakelite, then Pyrex, and finally he settled with Vitalium. So basically, if you can see here, this is on the left side is a mold which actually gives you the mold of glass, which was actually positioned between the femoral head and the acetabulum. Now the idea was to stimulate the growth of a reactive synovial tissue, a reactive fibrocartilage type of tissue on the side of the femur and on the side of the acetabulum. And after this tissue forms, he used to go and remove the glass. But obviously glass is not a very biomechanically strong material, and before many of the patients, before any such soft tissue could form, which could act as a lessening of the friction, the glass used to break. So he actually started experimenting with various other models apart from glass. He went into Bakelite, Viscoloid, Pyrex glass, and finally he settled for Vitalium, which was actually suggested by dentists. And this is one example of an X-ray of a Vitalium joint replacement mold arthroplasty, which was done by Dr. Smith Peterson. And to the right lower corner is a patient who had this surgery when he was 11 or 12 years old for slip capital epiphysis. And this is 60 years follow-up X-ray of the same patient. 60 is the so actually Smith Peterson he had a lot of success with this Vitalium mold arthroplasty, and in fact there are some discussions which say that modern joints, how will they ever last for 50-55 years? But this is one of the cases of Smith Peterson which has lasted. Not the only case, there are many cases which have lasted for 40-45 years. Italian. So the lessons learned from Smith Peterson's are he used to guide nature's repair. He didn't do anything major. He just slipped a mold arthroplasty. He actually positioned a foreign body between the femoral head and the acetabulum, and he actually guided nature's repair so that that smooth tissue forms between the femoral head and the acetabulum surfaces, and it helps in resting the friction. It's a Vitalium being biomechanically strong, he understood that more than glass, biomechanically strong material is required. He did more than 500 plus successful joint replacements, and there are papers which actually have reviewed patients for about 45 years post Smith Peterson approach, Smith Peterson replacement. And the funny thing is they didn't want any revision with any newer implants that were available at that period of time after 45 years of surgery. So it is a very successful surgery that he has done. But obviously all of us come down to the one big man who is the father of modern THA and probably the father of our bread also, because of his pioneering effort. We have developed the low friction arthroplasty, where he has used a metal femoral stem, he has used a polythene cup and a dental acrylic cement. These are the three principles of Chanley's total hip replacement. And his idea was small femoral head reduces wear due to smaller surface area. So these are the basic principles on which he started developing hip replacement, and it has become one of the most successful surgeries ever in the history of medicine, only because of the initial pioneering effect of Sir John Chanley. So here you can see him operating, and here is his implant where he is using the metal stem with a small femoral head, polythene cup, and he fixes it with a dental methacrylic cement. So the lessons that we have learned from John Chanley over past 5 decades are overall magnificently successful cemented arthroplasty spanning 5 decades. It is there for every one of us to see. He has standardized the technique basically of how to do a total hip replacement. Ultra high molecular polyethylene was first used by him, and there's a very beautiful anecdote where actually he refused to use this ultra high molecular weight polyethylene. It was only his assistant, in connivance with the mechanic of the gears, who manufactures gears, who did an overnight experiment, and next day morning he showed Sir John Chanley that this is a fantastic material which has got extreme resilience. And Sir John Chanley then went ahead with his assistant's words and used this ultra high molecular weight polyethylene in his patients. But over a period of time, an unknown disease known to man because of joint replacement started to be born, that is periprosthetic osteolysis, because of the micro wear, because of the polyethylene that was used. And maybe over a period of time, this has evolved to the discovery of larger heads, uncemmented components, revision stems, and a whole new gamut of profession and treatment of medical problems. So the new age problems, once basically we have solved the standardized technique of THA, became infections, embolism, that is a wear, the osteolysis and the subsidence, and improving bearings and fixations. So these new age problems that started to happen in hip replacement. Basically, it is very important. There are a lot of talks that are lined up after me, which will actually delve more deeper into these concepts. But basically, hip replacement implants have evolved as two primary components, the femoral component and the acetabular component, and each component has three elements: the element of structure, the element of fixation, the element of articulation. So these three areas have actually been on either side have been extensively researched and developed over a period of time. Which is a good articulating surface, which is the best structure for a acetabulum on the femur, and how best to fix the acetabular cup, how best to fix the femoral stem. So these have been actually the things that have gone ahead and improved over a period of time. So I'll just breeze through because it's a very large topic and a lot of other talks are lined up. Fixation, whether how to go ahead with press fit fixation, this actually started evolving where hard tissue opposition, not leading to atrophy and necrosis, and maintaining local tissue stresses became important. Cementing techniques improved, bone ingrowth and adhesion concepts started to evolve. So this is a example of a press fit stem which has bone ingrowth and bone on growth and no growth smooth surface. Cementing technique, vacuum centrifugation, pulsatile lavage, distal and centralizers, pressure cement. These have actually evolved the cement technique since Charlie, where he used to use a nurse's small finger to insert the cement into the femoral canal. From there, we have actually evolved to this, where there is a more stable cement mantle created because of the new techniques that have evolved. So this is again a femoral cemented stem where you can see how exactly the 2 mm gap helps in, please understand that the cement, whenever you're putting the cemented stem inside, it works more because of compression and it has got very less shear, tolerance. So it's very important to compress the cement between the femoral implant and the cortical and the bone so that you get a more amount of stable fixation. There was evolution into the collared cemented stems to prevent subsidence, to give better understanding of the depth of the femoral canal. But slowly over a period of time, I think because of the wrong load sharing, the collared stem started to fail. And then slowly over a period of time, because of the revisions required in femoral stem, the cementless stem evolved. Again, cementless stems can be of various types. They can be single wedge, double wedge, tapered, rectangle, cylindrical, modular, based on the version, or even anatomic. All these experimentations have been done over a period of 2 to 3 decades, trying to understand which is the best femoral stem given for the condition that is presented to us. So here you can see how exactly a flat taper stem sits into the canal, or how a dual taper stem sits into the canal. So basically the concept was to increase initial rigidity, evolve biological fixation, and balance the stress distribution. So this is how over a period of time, this is a Wagner type stem which helps in distal fixation. So basically, if you can see these three elements: fixation, articulation, and structure, these are the things that have been evolving over a period of time. And detailed discussion is beyond the scope of this time that I've been given. So here you can see a jumbo cup in acetabulum. This is for both the fixation and the structure. There's a Bird Schneider cup for preventing protrusion and in acetabular defects. And the lower one is a simple acetabular cup with shell and liner for simple primary joints. Hip approaches have evolved: posterior, Hardinge, anterior, Watson-Jones approach. Nowadays we hear the 2-incision approach, superior gluteal approach. So it is dynamic changes that are happening over a period of time in the evolution of hip arthroplasty. Minimal invasive surgery, there are proponents of this particular surgical technique, but I feel there is a high learning curve and potential implant malposition in this type of patients, in this type of techniques, and you have to be really very well trained and extremely high volume surgeon to do that. And I still believe in my teacher's talk where he says that big surgeons make big incisions. Computer navigation is again an evolution in hip arthroplasty, which we all know, and day by day it is leading to the next level, which is the robotics, where computer navigation, which is wedded to robotics, is giving the next evolution in hip arthroplasty. 3D printing is also a very important evolution, where initially 3D printing was used to understand how to tackle this particular defect. But now China has actually approved 3D printed joints to be implanted into human beings. So we are just going in a fast pace of development regarding the implant which are used. So in summary, THA is one of the world's most successful surgeries. History was unkind to attempts which did not respect biomechanics and infection. Modern THA principles are evolved from Charlie and still hold good. New age is about better fixations, better structural components, better articulations, and newer gadgets and computer assisted. And in my view, what is the future? We went through the era of resect and repair, where we used to do the excision arthroplasty, and we used to do arthrodesis. We went to through the age of restore. We are now in the era of replacement, but the next age belongs to growing natural bone and joint again. Probably one day, maybe in our career, we'll be seeing a joint being grown and being implanted into human beings. So thank you again. Thank you very much.
Thank you so much, Dr. Mithun. That was a wonderful talk on evolution of arthroplasty. And the next talk is going to be by Dr. Rajkumar on preoperative planning and templating. Over to you, Dr. Rajkumar. Can you share the screen?
I am now doing. Okay, can you all see the screen?
Yeah.
Okay. Good morning to all. I really like to thank Dr. Srinivas for inviting me, and very good topics and like the basics in total hip arthroplasty. And I'd like to thank Srinivas and Jansen for inviting me. So templating in a hip replacement, it's always there is a discussion whether templating is necessary or not. And majority of the surgeons, experienced surgeons will feel that many times they don't do a templating and they go ahead and do a hip replacement. But for young surgeons, I will always say yes, that templating is definitely is necessary. Why is that it is really necessary? Mainly to avoid this. When you begin as an arthroplasty surgeon, these are the things you would always like to avoid: the malposition of the implants, limb length discrepancy, dislocation, all these things. Definitely you don't want to see that. So how to avoid that? As a surgeon, we need to be very cautious to avoid that, and the best tool for avoiding that is templating. Definitely templating helps to avoid all these complications. So what is the good outcome in a total hip replacement? How is it really gauged? How do we think that, okay, we have done a good job when we get our offset and the limb length correct? If the offset and the limb length is correct, the stability issue and the clinical function is addressed. So the patient is happy and the outcome is good. So that is how you get it. So how to get this offset and limb length correct? Exactly by doing a templating. So templating helps in getting this correct. So what does templating provide us? So if this helps us to get it correct, what else helps us to provide? So it determines the choice of the implant. So what sort of implant we need to use, identifies the difficulties preoperatively. That is the most important thing. It identifies the difficulties and restores favorable biomechanics to the joint. So that takes care of the stability. So difficulties are identified and the stability is addressed. So the templating helps us in all these things. As a joint replacement surgeon, we want to keep the joint reaction force as minimal as possible and get the abductor tension correct. So these two things definitely restores the biomechanics. So for that, again, templating helps. So if the purpose of hip replacement, it evolves around the four things: the center of rotation, anteversion, both femoral and acetabular components, overall offset, and leg length. So all these things, again, templating helps. So what is the stepwise approach? First is assess the quality and magnification of the radiograph, identify the landmarks, anatomical, mechanical reference, and where is the deformity. Then template the acetabulum and template the femur. So for that, you have to have a good quality X-ray. See, there should not be any pelvic tilt. Pelvic tilt should not be there. And if you look at the sacrococcygeal, the sacrum should be in line with the pubic symphysis, and the operator foramen in the correct shape. And the proper rotation, the limb should not be rotated too much of externally or too much internally. So it should be in proper rotation. So to get that, and also for the magnification, I also always use the 3 centimeter Pitker ball. So once you place that and take an X-ray, and if you measure it to 3 centimeter, that means it's a 100% magnification. There are various ways to calculate nowadays. Digital X-rays are there, but still I use this kind of technique to have the magnification correct. So also you have to note down all the anatomical landmarks, all the, where is the shaft, where is the tip of the trochanter, acetabulum, teardrop, roof, everything. So you get identify the landmarks. So if you look at this picture, the first picture, it's the limb is 15 degrees internally rotated, and then X-ray is done. And then that gives you the correct anteversion. But if the femur is positioned neutral, then the anteversion changes. And if it goes into externally rotated, see how much of anteversion variation happens. So to get that correct, to get the correct X-ray, the limb has to be kept in 15 degrees of internal rotation. So this is an example how much of difference happens when you rotate the femur. So we have to be very careful in taking the proper X-ray. So identify the mechanical references: hip rotation center, femoral offset, acetabular offset, leg length. All these 4 things, as I said earlier, get these 4 things correct, you are getting a good outcome. So Ranawat triangle definitely helps. What is that? You draw a line, ischial tuberosity and the iliac crest, and then connect that. 1/5 of this is the height of the acetabulum, like 1/5 of the total pelvis height, 1/5 you calculate, and then from that teardrop you draw a line along the collar's line, and again to the lateral aspect, connect these two this thing. It's an isosceles triangle. So this is the place where exactly you want to place your cup, and that also gives you the center of the acetabulum, rotation of the acetabulum. So this helps, and then you get your femoral offset and acetabular offset. So then both combined together is the global offset. So this gives you the center of the rotation of the hip. Both acetabulum and the femoral offset gives the center of rotation of the hip. So template the acetabulum. So try to template the acetabulum first always, because it gives you the center of rotation. 3 important landmarks in acetabular templating. What is that? Base of the teardrop, first one. The second is draw a collar's line. Then the third one should be the superlateral edge of the acetabulum. So connect all these things and then keep the template templating. Do the templating and correct get your correct acetabular size. So why this helps? So you now, when you get the correct acetabular size, then as a surgeon, you know in the theater that how much of reaming. So you will be very cautious when you go nearer to that size. You will know, so that you don't overream. So nowadays, bone preservation, bone conserving is the most important thing. For the templating, really helps. So next is the femoral templating. It determines the hip offset and correction of limb length discrepancy. So you have to choose the correct stem. For that, again, use the femoral templating, and also it helps to get your osteotomy level correct. So these the femoral offset depends upon the length of the femoral neck and also the angle. So accordingly, your length also differs. So you have to be very, very careful to get your offset correct. You cannot keep on increasing the neck length. So that will increase the again the leg length. So which is not desirable. So 3 aspects of the femoral offset is very important. What is that? It gives the strength, range of motion, and stability. All 3 things is achieved by getting the femoral offset. So how to increase the femoral offset if you want to get it correct? There are various ways, by neck length increasing, decreasing the neck shaft angle, trochanteric osteotomy and acetabular component, you lateralize. But high offset femoral component is the desirable one, because the other things nowadays it is very trochanteric osteotomy, not many people do that. The other things, increasing the neck length, again, as I said, the leg length will be increased. So high offset, nowadays we use a lot of high offset femoral component to get the offset correct. So look at this example. Offset it's a coxa valga. So you see the center of femoral center of rotation is femur is there, but your acetabular center of rotation is down. So you have to bring it down according to the Ranawat triangle. So this is how you have to get your rotation offset correct. So these kind of cases nowadays you see in complex primary situations: difficult acetabulum, shallow acetabulum, deficient bone, again femoral side, coxa valga, high neck shaft angle, and more femoral anteversion. All these things you can see preoperatively by doing a templating. You will know, everybody will look at it and they will know that these are the things. But when you do a templating, you will note down each and every single point, and you will try to address it preoperatively. You will be prepared. So in a coxa valga, if you look at this example picture, in a coxa valga, if a standard stem is used, what will happen? You will increase the femoral offset. It increases the abductor tension. So you should not use that. So to avoid that, you have to use a smaller acetabular cup and medialize the cup. And you have to do a high femoral neck cut, head with a short neck and stem with a low offset. So these things, when you do a templating, you will know these are the things will come to your mind. So look at this example. It's a dysplastic hip, coxa valga. So this, you will know that a high hip center will avoid a bone grafting, small cup, medialize, and a modular implant to get your rotation versions correct. So all these things, if you do a templating preoperatively, you will be prepared. In a coxa vara situation, again, see this, you have to get the cup there. So for that, in coxa vara, if again a standard neck is used, what will happen? It decreases the femoral offset and it lowers the abductor tension. So to avoid that, to preserve the abductor tension, if you increase the neck length, limb length will be increased. So to avoid that, in a coxa vara situation, what you should do, you have to use a large acetabular component, lateralize it, low femoral neck cut, head with a long neck, and a stem with a high offset. So again, you will be prepared with all these things. If you do a templating. So if you take an uncemented stem like a correlate has got a high offset, low offset, you should know the implant and what offset it is providing. So this is again a coxa vara with a protrusio. And if you look at this, it is a reduced neck shaft angle, protrusio, coxa vara. Then if you do a templating, you will know how much of cup has to be lateralized, where you have to place the bone graft, and then how much of neck it has to be taken. So this is a post-op X-ray. One more case, post-operative post-traumatic arthritis challenges significant lateral offset. Neck osteotomy has been done previously. Abductors are weak. Choice of stem we have to know. So all these things in this situation, if you do the templating, you'll be prepared. Preoperatively, if you are well prepared, then you will address each and every single point of this. So here in this X-ray, you can see that I have used a distal loading stem because of the multiple screws. And then I have addressed the offset and the abductor weakness by using a high offset stem like a Wagner stem. And the cup is not too big. It has a small high hip center has happened. So with this, I was able to get the length correct. If you look at that, the length is also matched. So this is how that preoperative templating helps. Again, this is a different anatomy, altered proximal femoral anatomy, little challenging, complex primary case. Again, if you do the templating, you will see how much it helps. You need a modular implant like a SROM type. Again, here I have reversed the SROM sleeve and I got the offset correct. So if you are not prepared, if you don't plan and think about this, it is difficult to decide many things on table. So it is better to do a templating. So in this kind of situation, SROM modular stem helps. Post-traumatic situation, whenever you have an implant, you have to be very careful. Always do a proper preoperative X-ray. What is that? See the lateral X-ray, how much of bone is curved, how the lateral view, you can see the bone is curved so much. So in this situation, if you use a straight stem, it will be the high chances of a periprosthetic fracture. So preoperatively, if you know that, then you can do an ETO and then get your straight stem correct. So definitely this needs a distal loading, and for that ETO will help to get your bowed femur correct. So this is how a distal loading stem was inserted with the ETO. So acetabulum and femoral rotation, what is that? See, look at this arthritic hip. The acetabular rotation center is down, the femoral rotation center is above. So you do the templating, you know where exactly you, according to the limb length discrepancy, you do the osteotomy, bring down the femoral rotation center, match to the acetabular rotation center, and get your hip rotation center correct. So this templating definitely helps again to do the osteotomy also. So in conclusion, an accurate and careful preoperative templating definitely results in a balanced hip reconstruction. Nowadays, more importance is given to offset and limb length stability. So by doing templating, you can get the leg length and the offset correct. Thank you.
Thank you so much, Dr. Rajkumar. That's an excellent talk on preoperative planning. So we'll take questions at the end, and now we go ahead with Dr. Satish Reddy's talk, which is on cemented prosthesis, femoral and acetabular components, philosophy and technique. Dr. Satish Reddy, over to you, sir. Can you share your screen?
Just starting, just hang on a second. Can you see the screen now?
Yeah, yes.
Good morning, all. Thank you, Srinivas and Dr. Somshekhar, for asking me to do this. I'll be briefly taking you through the just a second, through the learning objectives for the day would be the philosophy of cemented hip replacement and how I do a hip replacement, a couple of slides on the advantages as well as evidence for cemented hip replacement. So some of the models which are available in the market, you can see there are plenty of polished, smooth tapered stems available, and it is up to us to choose what we want to do. And the word revolution is used very commonly for many people and procedures. I think the true revolution for hip replacement was what was introduced by Sir John Chanley as the low friction arthroplasty. And the 5 important components of low friction arthroplasty as described by him were not only the implants, it was deepening of the socket and lengthening of the abductor lever arm to improve the mechanics, using of bone cement to fix the stem, or the cup, and use of ultra high molecular polyethylene, as well as using a 22.2 femoral head size, which was giving us a optimum wear characteristics. So what the types of stems which are there for the cemented hip replacement, the 2 major groups are the force closed or the taper slip, where you have a double or a triple taper to the stem. These are super smoothly polished stems which allow a controlled subsidence of the stem into the cement, as well as they're collarless. If you are implanting a smooth tapered slip stem, this is what usually happens. A millimeter or 2 of subsidence happens into the femoral side. And this leads to this wedge-shaped implant getting further stabilized by getting stuck inside. And these movement, which is initial subsidence, gets transferred onto the whole of femur as hoop stresses and gives stability as well as loads the whole upper end of the femur. And if you have had a cylindrical stem, then you'll realize that this thing just slips in as much as it wants to. The next type of stem which is available is the shape closed or the composite beam. Here the surface of the stem is roughly finished, and this rough finish interlocks into the bone cement, and this bone cement is again interlocking into the shaft of femur. This is what leads to a composite structure, so hence it is called the composite beam. And there is no subsidence which is allowed in this. Subsidence is actually detrimental, and the collar is useful to prevent subsidence. There are further sub-classification in terms of based on the amount of fit into the canal, or also the shape of the stem in terms of being anatomical or non-anatomical. But these are the 2 commonest things which are available. So an example of how both the structures behave in subsidence: in smooth polished stem, usually the subsidence happens at the bone implant interface, and it leads to further stability. And when you come to the rough finished stems, the subsidence could happen between the bone and the cement interface, as well as the implant and the cement interface. And both these lead to the generation of debris and can lead to further osteolysis. The acetabulum, like I said, is the ultra high molecular weight polyethylene, and we are getting the newer polys which have various methods to increase the wear characteristics or the longevity of the implant. And the commonest structural changes are the structural differences are the low profile or the high profile liners. And then the third important component in this is the bone cement. We all know the polymer and monomer. We have an exothermic reaction leading to solidification of the cement and acting as a grout. So when we introduce this cement during the Duffy phase, this cancellous bone, which you can see on a microscopic picture, this is where into which it interdigitates and acts as a good filler. And the more interdigitation which you can achieve, the better it is for the stability of the implant. So the various generations of cement mixing have happened. Now the third generation, which we are all using, are the vacuum or the vacuum mix or the centrifugation. And the canal preparation occurs by aggressive rasping of the canal with brushing and pulsatile lavage. It is inserted with a cement gun retrogradely, pressurized with the help of a pressurizer. And with all this happens because you're able to introduce a distal canal plug. And the centralizers nowadays we get for both proximal as well as distal centralizers are available to help us position the implant in the right place in the canal. So what I do, which I've been using exclusively for the past decade and a half, has been most of my cemented hip replacements are done with Exeter. I don't have any conflict of interest, but you will see a lot of a lot of my talks centered around Exeter. Once upon a time, I was on their rolls. Nowadays, I'm not, but I still use it. It's a double tapered construct, highly polished stainless steel, 125 degrees neck angle, which is a collarless stem, and a hollow centralizer. And all these components are interdependent. And if you remove any one of these components, the function or the longevity of the implant actually deteriorates. All these are necessary for us to get a good result. And what is the centralizer? It is a hollow structure which helps us in placing the implant in the center of the femur, as well as it has got a place which allows subsidence of the implant and prevents end bearing of the implant. It is made out of pre-polymerized PMMA. And there are two varieties which have come in the pack, which is a wingless as well as winged one. Winged one is what we use in a simple, straightforward cemented THR. Wingless, it has the option is available for using in a revision or when the canal is too narrow, which is less than 10 millimeters. So the advantage of using this stem is that you can actually modify this the various parameters which are required in all the three planes, the x-axis, y-axis, and z-axis, independent of each other. And in the y-axis, you can adjust the leg length alone without changing any of the other two axes. You have the three markings on the stem, which is the difference between each marking is 4 mm, and the lowest and the highest, the proximal most and the distal mode, the difference is 8 mm. Your placement of the stem is not limited to only these markings, but this gives an idea of how much we can change our leg length independently. Coming to the X-plane, the offset, this system has multiple, about 7 offset options, and different sizes are available with each of these offsets. And we can change the offset independent of the y-axis also. And then the heads. These help us in changing the y-axis as well as the x-axis simultaneously. That is, you make changes along the z-axis. You have the 0, which is not going to change any leg length or the offset. You have -4, +4, and +8. These help us in changing the offset as well as the leg length. The change in these head sizes actually leads to a greater change in the offset. About 60% of the length, which is mentioned here, goes towards changing of the offset, and about 40% is what goes to changing of the leg length. I mean, the reason why we need to go through all these things is you know your implants well, then you know you can do a better surgery because you have understood your implants. So how do I do it? I'm a posterior approach person. I do it in the lateral position using the Chanley supports on the sacrum as well as the symphysis in the front. And if there is an error in terms of positioning, I like it to be err on the side of floppy towards me. It will help me in preventing the avoiding the retroversion of the cup. So I going through the fascia, and I identify the short external rotators, use Ethibond to apply a couple of stay switches. And this is when if I'm doing a complex primary, I would do a marking and leg length measurements, which I can use as a reference after doing the trial implantation. Then move on to dislocation, and then cut the neck angle at about 45 degrees to the shaft. If you know the kind of person who doesn't like to do too much of soft tissue dissection and leave all the attachments present, you can also look at the blade being angled from the piriform fossa and being parallel to the articular cartilage. It also gives you approximately the same kind of neck cut. And then moving on to the preparation of the acetabulum, I would usually use 3 retractors and excise the labrum and the osteophytes. I use a 46 size reamer straight down, vertically down, reaching into the true acetabulum, and then start reaming progressively in the direction we want to ream, usually, and up to it becoming a snug fit in the AP directions. In case there is what you call sclerotic bone, I apply I make a couple of holes as anchor holes. But if there is sufficient amount of cancellous bone which has been exposed, then I don't make anchor holes on a routine basis for every patient. And do a trial, and then wash it out, and then plan for implantation of the acetabulum. Now the important thing is, how do we mix these cements also? I usually leave my cement outside just outside the operating room door. The operating room is pretty cold. Then I bring it in when I want to actually start mixing it. Mix it for about a minute, and then allow the bowl to sit aside for about a minute. Allow all the bubbles to come out. It will improve the porosity as well as remove any voids which are there, and then gently mix after that. Once it becomes a duffy ball, I apply it into the acetabulum. Digital pressure or use a pressurizer, whichever is your choice. I usually apply digital pressure. apply minimum amount of cement in the inferior aspect and take it up as much as you want. And then I insert the socket. The exciter handle, I like it because it comes with an angle onto which the cup sits, and the vertical rod which gives me the 40-degree abduction I want when I place it vertically to the floor. And also it'll allow me to do the closed book method, where you just place the implant inferiorly and crank your handle superiorly, so that you close the acetabulum, and that will allow the majority of the cement to not to go inferiorly, and that prevents leakage of the cement inferiorly. And then you can rotate it for your anti-version. Once the implant is in place and I feel the cement is starting to set, I remove this and use a ball pusher to hold to pressurize the implant, maybe give a couple of taps with a hammer. This will prevent our movements in a hand, our vibrations and movements from a hand from being transmitted to the cup. The ball pusher will absorb all the movements in our hand, which are inevitable, I guess. So once this is done, I move on to the femur. This the videos are some of the really old videos, but I think these were given to me by Ross Crawford, which was one of the doyens of cemented hip replacement. So I thought it'll be interesting for you to watch. So I've put these up here. Start off with the box chisel, go underneath the trochanter and go into the lateral thick bone and get into the femur, remove the chunk of the intramedullary contents from the proximal femur, and then use a canal finder. You have two diameters of canal finder in the exciter set. Use both of them and get into the canal. That is where your implant will be positioned along this. Once you have the canal finder in place, once you have done that, then you can take it out and start broaching. In some sets, when I don't have a proper box chisel, I also use an implant which is made locally in one of the other sets called not an implant, an instrument called a lateralizer, which helps me in broaching the lateral aspect of the femur, or use the smallest broach too. If you have a sharp new broach, you can use that as a lateralizer. I think that's important to get an adequate volume of the broach stem inside. So this is the lateralizer I was talking about. It's a nifty little instrument for us to be able to get into as much lateral as you want in the femur. So once the broaching is done and you have you have your whatever you have trialed and you're happy with the broach, then you do a trial reduction. You can check for limb. You have to check for limb lengthening. You have to check for position to dislocate, and the position to dislocate usually is checked in about 30 degrees of flexion and about 10 degrees of adduction. That's when you want to check how stable the implant is. And then you also check for anterior capsular tension. Some people do talk about reducing the neck length to reduce the tension, but I think it is fair that you release the anterior capsule to reduce the capsular tension and achieve better external rotation. Now coming to the cementing on the femur, you have to wash you have to trial the canal and find out what is the sounds which are provided in the set, and you try to find out what is the size of the cement restrictor you want to put in, and you have an implant shaped introducer through which you will introduce the cement restrictor. Only then you should start washing. Do not wash it before you introduce the restrictor. Thereby, you are actually pushing whatever external material is there throughout the femoral intramedullary canal. Once this is done, you start washing with pulse lavage and a brush. This is what we used to. This is what I used to do in the initial days, but now I've stopped using brushes because the quality of brushes we get here, I'm finding that we leave behind some of these plastic bristles, and I'm unhappy with leaving those plastic bristles behind. And nowadays, I'm using a curette to take out all the loose cancellous bone, and then I leave a infant feeding tube inside and pack it with hydrogen peroxide soap gauze to achieve some amount of hemostasis. And during this time, the cement is getting prepped. Usually, again, the same thing, do mix it for a minute, allow it to sit for a minute, and then pour it into the cement gun. And I'll usually be going in at around 4.5 to 5 minutes when I start to introduce the cement in a retrograde fashion. So, and once the cement is filled up into the proximal canal, this is what we call a half moon. I think this half moon has been working with me for the last 6-7 years. I had bought a couple and they still stick with me. So thread this half moon onto the cement gun, and make an mark with a scalpel at the tip of it, and then you can break it off then, and then reintroduce this into the canal. Put the half moon on the face of the proximal femoral canal. You will get a tight seal, and then start pushing cement in again. This is what pressurizes it, and you can actually see the so-called sweating of the proximal femur. And once the cement is, so this is what happens. The time you start to pressurize, the interdigitation improves because of the pressure proximally as well as distally. You have the cement restricted, it doesn't allow the cement to flow further down. So once the implant is, once the cement is duffy, I go in with an implant. I go in when it is so duffy that the last couple of millimeters, I may have to strike it with a hammer to seat it properly. And use this, put a finger on the medial side and push it in while maintaining pressure, and push the implant inside. And once the implant is seated, I remove the handle. Again, use this little divot which you can see on the shoulder of the implant as a point on which I put a sharp screwdriver like thing to hold pressure. I don't want the handle is too tight, but it will form one continuous construct, and your hand movements tend to get transmitted to the implant. To avoid that, I use this divot to hold the implant in place and maintain pressure. Once this is done, you can trial again with your heads, whichever you want. You look at the you retrial and implant the final head and reattach the posterior soft tissue. And you should end up with something like this. The advantage with this is, I think you have multiple length options, multiple offset options, multiple version options, and you can control each of them separately. So the advantage of a cemented hip replacement is survivorship. You know that it is showing excellent results across many registries. The versatility, like I said, you can actually practically talk about infinite positions at which you can place the implant. The incidence of periprosthetic fractures with uncemented implants has been on the higher side. A word of caution is, of the cemented implants, there is an increase in the incidence of periprosthetic fractures for the wedge-shaped implants or the taper implants. In case you want to deliver antibiotic, on a long, you can mix antibiotics with the cement, and that's another option which is available. And when I was a postgraduate, we used to talk about the difficulty in removing cement when you want to do a revision, but now cement and cement revision is a well-established concept. And I think the procedure is fairly forgiving. I remember Ross Crawford, about 20 years back, telling that just pour cement into a proximal femur and stick a excitor in, and it will work for 15-20 years. The disadvantages is the increase in the OR time, maybe about 15 minutes on an average would be the increase in OR time, but the cost benefit, I think, is definitely there, especially for the Indian scenario. And there is talk about cement implantation syndrome, but for some reason, it's still an unexplained thing, but for some reason, it seems to be occurring more in patients for whom we are doing a total hip for a fracture neck of femur rather than a primary. And just one evidence slide I have is this one which talks about the results across 5 international registries and a bunch of randomized controlled trials. And it says, we conclude that the cemented fixation had better overall long-term survivorship than cementless fixation in primary total hip arthroplasty. After age stratification, cemented fixation had better survival in older patients, while cementless fixation had better survival in younger patients. And periprosthetic fractures are more common in cementless, and it needs to be explained to the patient. So I think there is still a big role for cemented hip replacement in our country. And if you look at the European registries, again, the number of people doing cemented hip replacement is again going up, and it is predicted to be the major share by 2024. The American perspective is where we need to understand they're doing more of uncemented hips than compared to the cemented hips. And I think Dr. Sridhar will be able to give us a fair idea about it. Thank you.
Thank you so much, Dr. Satish, for a wonderful talk and nice videos. And let us move on with the next part, that is uncemented arthroplasty by Dr. Rajkumar again. So, Dr. Rajkumar, over to you.
Yeah, I'm sharing now. Thanks once again, Dr. Srinivas. Can you see me? The screen also?
Yep. Yes.
Okay. Yeah. Okay. So uncemented total hip replacement, the philosophy. My talk is going to be a overview of the uncemented hip replacement, because my next speaker, Dr. Sridhar and then Mahesh, are all going to talk in detail about the selection of the processes. So my talk is on the philosophy. So let me keep it little short and crisp. Cementless fixation. So the buzzword here is the osseointegration. So the osseointegration is the most important point in the success of a cementless fixation. So what is that? It is the attachment of lamellar bone to implants without intervening fibrous tissue. The most critical point here is without intervening the fibrous tissue. So if this happens, then the cementless fixation becomes a successful entity. So this happens between 4 to 12 weeks of time in the initial period, but it still continues for 3 years. That's a very interesting point here, because it continues over the period of 3 years. We all think that after 3 months or 4 months we can, but still it continues. That's what the evidence says. So if you look at the cementless fixation, to get the osteointegration, what is the most important thing? There should be an adequate osseous contact between the implant and the bone, and a stable firm fixation. This is the two again important things. For good osteointegration, you need a good bone contact with the implant and a stable fixation. What will happen? This will minimize the micromotion. Why the micromotion is not good? The micromotion, if it is more than 150 microns, leads to fibrous tissue formation. If it is between 40 and 150, it gives a bone and fiber. It's a mixed formation, bone and fibrous tissue, which is not good. But if it is less than 20, then we get a bony formation. The osteointegration is good if the micromotion is as less as possible. So that is the aim. That should be the aim for a arthroplasty surgeon. So what are the factors impacting in osteointegration? So it is like the implant design, appropriate surface treatment, that is the coating, the stability, initial stability, and then the patient osteogenesis. So the first three things are very, very important, which is under our control. So implant design, surface coating, and then the stability, which is achieved by the surgeon. So to get a good fixation, so the initial fixation, as I said, it should be very, very good, is obtained by press fitting, as a slightly oversized component is used compared to the last broach or the reamer. So that initial fixation is the most important thing to get a good osteointegration. So factors that influence the initial stability or a good fixation is again the design or the geometry of the implant, the coating, the how much of roughness or the porosity, and again the technique of preparation, the reaming, the entire preparation of the bone, both in the acetabulum and in the femur, and then finally the bone quality. So according to the bone quality, we have to take more lot of decisions which one to select. So all these things helps to get a good fixation. Apart from that, the engineering, that is the surface coating and the implant metal itself helps. What is that? It helps in two ways. Either the bone ingrows or overgrows. So the bone grows into the coating, like in a sintered beads or a fiber mesh or a porous metals. Nowadays, a lot of implants are porous metals. So it grows into that porous material. So it requires a pore size of more than 50 to 400 microns. The more the porosity, the more the bone ingrowth. And the percentage of voids, that is the porosity, within the coating should be between 30 to 40% to maintain a mechanical strength. So the porosity should be between 30 to 40% of the entire coating. So then the bone ingrowth is good. So bone on growth happens in these kind of materials. That is a grid blasted, plasma spray titanium, and a HA coated, like all your Corals and Wagners. All those things are all happens. The bone grows over the implant, whereas in a stem like an accolade or a summit, the bone grows into the coatings. So coming to the uncemented cups, if you look at that, it has got various shapes and coatings, and you have to select accordingly to the nature of the bone and also the need, perioperative need. So your selection should be accordingly. So it can be an HA coated or a porous coated. It can be a tantalum coating. So it can be any shape. So it has to be selected according to the need. So evolution of the hemispherical cups, it has happened from 1970s to 2000. Again, once people started seeing a lot of failures in an cemented hip system, then this uncemented cups and stems got started evolving. and from 1970s to 2000, the size and shapes changed. So initially it started with a cylindrical, then it became square, cone type, oblong cup, and now it is a hemispherical cup. The first generation cup, the poly was very thick and it was extruding out. So the wear was very high, and then impingement and dislocation rates were high in the first generation. Second generation, congruity improved, the coating became better, the poly became protrusion became less, and they made a thicker poly. But now the third generation one, there is no poly extrusion. It's a neutral liner, and then a newly highly cross-linked liners are available, and the cups have become hemispherical. So in these kind of hemispherical cups nowadays, it is either the titanium coatings or the tantalum coatings or the plasma sprayed or grid place. These all helps in a good stability fixation, and also helps in bony integration, that is the osteo integration. So as I told already about the porosity, the better the porosity, the better the stability and the bony ingrowth. So if you look at the various metals, trabecular metals, titanium, Gription, all these materials, the porosity is there like 75% to 65%. The trabecular metal has got the highest porosity. So that is why in revision cases, we tend to use more of trabecular metal implants. So if you look at the design, this is the main important design which you have to keep it in mind. The hemispherical cup and the elliptical cup. The hemispherical cup is deep and it is uniform in preparation, and the bone growth is uniform again. And the press fit technique gets good, is done in very nicely in these kind of hemispherical cups. Whereas in an elliptical cup, it is very shallow and the base has less bone growth. So you have to be line to line reaming has to be done in these kind of elliptical cups. So to give you an example, the Depu's Duralock is a sub-hemispherical. It is not truly a hemispherical cup, whereas the Pinnacle cup is a fully hemispherical. Okay. So if you look at the literature, they say the hemispherical cups, the Pinnacle hemispherical cups has achieved a very good results, longevity when compared to the Duralock cup. Still we have achieved a very good results with the Duralock, but nowadays the most preferred is a hemispherical. So the third generation hemispherical cup, like a continuum cup or a trabecular metal T-Mars, are all good examples and a very good porosity materials. So technique of fixation, definitely everyone will be knowing here about the press fit. You have to ream a little lesser than the actual cup. But having said that, you have to know what kind of cup you are dealing with. You cannot, for all the cups, it is not the same. So it varies from system to system, company to company. So you have to, as a surgeon, you have to know exactly. But as a general rule, the acetabular reamer, the outer diameter, is the one which matches the cup also. So the outer diameter is the most important thing, and you select according to the cup, whether according to the reamer, whether you need to under ream or ream little line to line. And also it depends upon the size of the cup. The bigger the cup, you have to do little bit of under reaming, and if it is a smaller cups, you might need to do a line to line reaming as well. So it also helps in good press fit. The press fit technique, because the acetabulum the acetabulum is like an elasticity. It expands when the original cup goes inside, and it gives you a good fixation. So if you look at the literature, Dr. Satish showed a very good article about the good cemented outcomes, longevity, but there are some reports also about the uncemented cup also. So here you see that 20 years cementless acetabular components has given a very good results when compared to a cemented. So what works best, a cemented or a cementless system? It depends upon the surgeon and the patient's need. Based on that, the selection has to be appropriate. So both gives excellent results. So if you look at the cementless cups, it helps in biological ingrowth, excellent results. It all depends upon the bony quality, design, and also the coating. So cementless cups nowadays, more cementless cups are used, particularly in revisions, most preferred ones. But if it is an older age group, you can still use a cemented cup. Sorry, cementless and an uncemented. So few examples about the uncemented cups. It is used in all age groups, 20 years, post-traumatic arthritis. In these kind of very complex primary situations, you should have a smaller cups, that is the bantam cups, 38 mm cups. So you need to know the system. You need to know because if you use these kind of cups, the head size will be only 22. So these kind of 40-year-old male arthritis, both sides, the cups, again, hemispherical cups, Pinnacle, poro coated. So 60-year-old, again, uncemented cups. But 79-year-old female, the most preferred choice will be a cemented cup and a stem. But still, it depends upon the bone quality. Here, even though patient is 79-year-old, the bone quality was good. So I had used a uncemented system, uncemented cup and a stem. Again, a 74-year-old, the bone quality is good. Again, an hemispherical cup, both sides, and an uncemented stem. So the selection of the cup, whether it is an uncemented or a cemented, should be based on the patient's bone quality and the surgeon's experience. And this literature says 100% uncemented comes excellent results. Daniel Berry's article. So to conclude about the uncemented cups, third generation uncemented hemispherical cups with a highly cross-linked poly and a ceramic head is the well time tested and the most preferred in a total hip replacement as in nowadays in the current scenario. In an instability situation where you will tend to deal with dislocations and in revision scenarios and also post-traumatic and neck of femur fracture, all these situations, instability happens. For that, previously we used to modify the technique or use a larger femoral head or constrained liner. But nowadays, the dual mobility cup, an uncemented or a cemented dual mobility cup helps a lot because it evolved from a low concept of low friction Chanleys and also the large femoral head concept. Combined together, it gains a lot of attention, both uncemented and cemented, very, very, very low risk for dislocation because it has got a two articulation and increases the head neck ratio and the jump distance. So you get a good ROM when compared to the regular total hip replacement. But the key point here is according to the size of the cup, either your head size will be 22 or a 28. So it gives good stability, excellent range of motion and lower friction and lower wear. But the key point here is it has got a lot of modularity, so that you have to keep it in mind. So Stryker has got a very dual mobility system, but as nowadays a lot of companies are coming up with their own dual mobility system. So the indication should be very, very clear in these dual mobilities cups if you are using the neuromuscular diseases, primary hip THRs and neck of femur fractures. Nowadays, again, a lot of surgeons are using this in tumor resections and revision THR and neuromuscular problems are the most clear indications for a dual mobility. It should not be used in routine cases because still we don't have a long-term results. So coming to uncemented stems, again, because of the failure of cemented stems where people started looking into the uncemented, this started evolving in 1956 and 60s. So McKevy and Watson Farrar, they tried the initial uncemented systems like this, and they achieved a fair results. Around 50 to 51% of good to fair results were achieved. And then slowly it got started evolving. In 1960s, the design started changing. Metal on metal came into work, but the acetabular cup was used with a single screw. So it was metal on metal again. But then again, with the failures and more of research, in 1980s, the development of material engineering happened, and that really revolutionized the cementless arthroplasty. So Mont and Kanuja et al, they have there are a lot of stem designs and shapes, but they have concised, they have clearly defined, they have developed a classification system, and this classification system definitely helps, and it is more practical. So what is that? It is the type 1 is a single wedge processes. It is the wedge is only in one plane, that is from medial to lateral. The anteroposterior plane is always constant. It is flat and thin. Like example is a Accolade 2 type of or an ML taper Zimmer stem, where the proximal portion is wide and medial lateral. So here the preparation is mainly with the broaching. These kind of stems has achieved excellent result. This is the type 1, that is a single wedge or a single taper. The double tapered metaphyseal filling stems are the type 2 stems. It has got the proximal contact is the proximal, the coating is very much different here. The porosity is in the proximal portion. It is a double wedged in a metaphyseal filling stem. The distal portion is again, the coating is a titanium, and it will be the bone overgrowth happens in the distal portion. Bony ingrowth happens in the proximal portion. The preparation involves both. You have to prepare the distal femur, distal femur a little bit, and then the broaching has to happen in the proximal portion. The type 3 for mainly in the complex situations, type 3, it is again divided into 3A, 3B, 3C. Particularly in the 3B, like the Cohn-Wagner's, it is useful in a complex deformed cases in the because it gives very good flexibility in the controlling the version, and it has got good splines and fins which purchases into the bone cortex of into the cortex and gives good rotational and axial stability. So these stems are very commonly used. And then the type 4 is the distal loading cylindrical stems. Even though this is not preferred nowadays, previously a lot of revision surgeries happened with these kind of stems because it's a distal loading stem. Cobalt chrome stems, as you know, this kind of stems nowadays we tend to see more of thigh pains, now not preferred that much. But type 5 very commonly used modular systems like an SROM in complex deformity dysplastic hips. We use a lot of these kind of stems, and it has given excellent results. Type 5. Type 6, again, not nowadays, not much preferred. It's a curved stem, anatomical, fit and fill stem, but a lot of failures. The literature wise, it has not given good longevity, not much used. So DOR classification again helps us in selection of the correct processes, in which situation, which type of stem has to be used, or whether a cemented or an uncemented. Like few examples here, DOR type A, still we can use a corail stem, but the preparation has to be proper. So in an AP narrow canal like this, I have used a Accolade 2 stem and a dual mobility. Why? Because this patient had a history of epileptic. So I have used a dual mobility with Accolade 2 stem. Again, a DOR type A narrow stem. Here a summit stem is used because summit system has got a low offset. It is a low offset when compared to a corail. So these kind of situations where you need a low offset stem, you can use this. You can select the types 2 double wedge stems like summit. Idiopathic chondrolysis, an example where this is a deformity is very complex. So in this situation, Korn-Wagner was used to get control of the version. In post-septic sequelae, Crow type 4 dysplasia, you need to do a subtrochanteric osteotomy. So again, a modular stem, type 2. A trochanteric fracture with an arthritis and a protrusio, definitely you need a distal loading stem. So you have to select the stem according to the knee, according to the bone quality and the need. So disadvantages of the cementless system, again, proximal femoral fracture, periprosthetic fractures, loosening, thigh pain, and stretching. These are the 4 most important disadvantages. To overcome that, you have to know the design, the coating, what kind of surface coating, and the technique of preparation, which is the surgeon's control. Surgeon has to take care, and the bony quality. With all these things, you have to minimize the disadvantages of the cementless system. So any design may be acceptable for routine cases, but majority of the times you will be using a type 3 or 4 or 5, which are used for dealing the complex primary. So as an orthopedic surgeon, you have to select the implant which is safe, cost effective, and time improvement implants with good evidence. If too many choices, then the selection should be based on experience and the surgeon, and which gives a good quality surgery for the patient. Thank you.
Thank you so much, Dr. Rajkumar. That was a nice talk on uncemented hip replacement and philosophy. Let us invite Dr. Sridhar Reddy from New York to talk on selection, factors to consider while choosing the right cupped stem, a US perspective. So I know it is, thank you very much, Dr. Sridhar, for accepting, because it's definitely hard hours for you to spend this time. Thank you so much. Over to you, sir. Not able to.
Sir, you are muted. Muted.
You are muted.
Can you hear me okay now?
Yeah.
It's nice to be on this panel. Thank you, Sri, for inviting me on this panel. I recognize some of them. Satish Reddy trained me when I was in India. I also recognize Kiran there, and you too. I trained in Hyderabad. I did my PG in Usmania General Hospital, then came to New York, and I did my residency in Buffalo and trained under Dan Berry, the paper that was quoted by Raj Kumar at Mayo Clinic. And I'm back as faculty at University at Buffalo for past 10 years. Again, I want to congratulate all the prior speakers on excellent talk. This is a top quality faculty, and I'm honored to be here. Now, conflict of interest, I'm a consultant for Stryker Orthopedics. I'm also a consultant and on Speaker Bureau for Avanos Medical, which basically deals with pain pumps, intra-articular, peri-articular blockade pumps, which I'm helping design. Now, disclaimer for this talk. The first two disclaimers that are not here are, it's, as Sri said, it's 12:30. If I say something awkward, it's late at night, a little sleepy, so maybe you can forgive me on that. Now, lot of slides that I'm going to show have already been addressed by a lot of excellent faculty ahead of me too. So it might be a little repetitive. So disclaimer for this talk is that this is a regional perspective. Whenever you're selecting an implant, it depends on the area, whether you're in Europe, India, or US, depending on various factors. Nobody's right or wrong. It's just a perspective based on the situation on the ground there. It's also dependent on experience, what they're used to and what works well in their hands. And the perspective also depends on inherent bias a person might have with regards to certain implant, and also based on their experience, what works well in their hands. The other factors to consider when you're selecting an implant are the amount of time it takes to do the procedure, OR time, the implant cost, and basically who's paying for this surgery. That matters a lot. If you're paying it out of your pocket, certainly you might think about it a certain way, whereas if somebody else, like an insurance company, is paying, your thought process might change a little bit. So I would invite everyone to look into these factors prior to deciding on surgery or which implant you need to pick. The questions to ask anytime somebody talks to you about a new technique or any technique at all, as a matter of fact, are, the first question you need to ask is this better for the patient? The second question you need to ask is this better for me as a surgeon? The third question you need to ask is this better for the hospital that you're working for? Number four is this better for the healthcare in general for the country? So if you go through this systematically, 1, 2, 3, 4, you would hopefully make a right choice for your situation where you're working at. Now, we've had extensive talks on cemented and uncemented acetabular components. The main thing that we need to consider is what are the pros and cons of either of them. Now, let's start off with acetabular components. When we're talking about cemented acetabular components, the advantage is they're cheaper. They can have similar survivorship, especially if done well by an experienced person. And you can get a bigger bearing surface for the similar size socket, especially in a smaller person. So those are the main advantages of a cemented acetabular component. Now, what's the problem with a cemented acetabular component? It is time consuming. It takes longer than doing an uncemented acetabular component. It is difficult to do this surgery, a cemented acetabular component. It's difficult to achieve a bloodless field, especially unless you're doing hypotensive anesthesia. And even then, especially on the acetabular side, there might be some problems with bleeding. And whenever there's a bloody field, cement interdigitation is not that good. And whenever cement interdigitation is not that good, and when you have lucent lines, the long-term failure rate of cemented acetabular component is high. It is certainly more technically demanding, where you're paying attention simultaneously to pressurizing the cement and also holding the position of the component. The other issue is that when you pressurize the cement into the bone, the cement goes in through the cancellous bone, thereby extending the area of fixation. So cement intrudes into the cancellous bone. Now, God forbid if this patient gets infected and you're trying to remove the acetabular component, you have to remove all that cement, so which will potentially lead to more bone loss. And also you're afraid of leaving some foreign body there in a case of infection, which might lead to recurrence of infection. Cement bond usually gets weaker with time, especially in active patients. There is no scope for modularity in a cemented acetabular component, which is useful for the surgeon. And there's no ability to change the cup position once you have put that in there, unlike uncemented components where you can change the position of the cup and fix it with coupled screws. Again, as I said earlier, lucent lines immediate post-op lead to early failure. In general, most of the literature shows a lower second decade survivorship, but I would also yield the fact that majority of these studies had non-highly cross-linked poly, and there might be some role of non-cross-linked poly in that lower second decade survivorship in the cemented component, cemented establer component. Excuse me, my screen is frozen. Yeah. Now, when you're talking about uncemented establer components, the advantages are it's easier to do and less time consuming. You have the ability to change the cup position. If you put the cup in and you do an intra-op X-ray or do the femur and trial it and move the femur around and you don't like the stability, you could change the cup position to more anteversion or more abduction depending on the impingement that you may encounter. It turns out that the cup position seems to be the most important determinant in the long-term success of a total hip arthroplasty among all the factors that we could change. Modularity is an advantage. We could use an elevated or a phase-changing liner to change the version or abduction. Also, usage of dual mobility liner in certain difficult cases is also useful. To my knowledge, there's no good cemented dual mobility construct at this point. Again, biologic bond becomes stronger with time, especially in active persons. Just like with fracture healing, over a period of time, the bone remodels and it becomes stronger as long as the bone heals. Better 3D surfaces, like quoted by Dr. Raj Kumar, three-dimensional coated is where there's a porous ingrowth surface like titanium, tritanium, tantalum, porocoat. All these have improved the survivorship as opposed to a two-dimensional coated surfaces in the acetabulum. On the femoral side, 2D or 3D doesn't matter. On the acetabulum side, three-dimensional coated surfaces have improved the outcome. And when you're going to remove the femoral acetabular component in a case of infection, there's no concern of retained foreign body or a small piece of cement that can lead to failure of treatment of infection. The downside of uncemented acetabular components are biology needs to integrate. There's a higher incidence of early failure, as Dr. Rajkumar said, especially in patients with severe osteoporosis, radiation osteonecrosis. Osteoporosis, there could be intraoperative fracture, especially if you under-ream the acetabulum and pound it in without much experience. You can lead to intraoperative fracture. Radiation osteonecrosis will lead to decreased biology in the site, and that might lead to early failure because of failure of osseointegration. Now, stress shielding is an issue with uncemented acetabular components too. I'm going to show a case towards the end of this presentation, where a patient had a problem with uncemented cup, had a stress shielding, and led to a big problem down the line. So uncemented acetabulum are not without problem. Cost of the implant is an issue, but it is offset to a certain extent by the time saved. Time is money, especially in a high volume center where there's demand for the OR time. Every minute costs. At our place, the cost of every minute in the operating room is $100. On an average, in the United States, it's $37 per minute cost based on the article published in JAMA. So if you're going to add 30 minutes to the case, you have to think that, at least in our hospital, I'm adding $3,000 to the case cost. Removal of uncemented components, especially in a large components with stress shielded bones, can be a challenge. It can cause iatrogenic fracture, especially if you're trying to remove in a stress shielded porotic bone. That's something that we need to consider as a drawback of uncemented components. So these are pros and cons of cemented and uncemented acetabular components. Now, let's go back to those first four questions we talked about: cemented, uncemented versus cemented acetabulums. Is it better for the patient? It may be, maybe not. The reason why it might be better is because of the modularity, ability to change the cup position, biologic bond, especially if it integrates, might become stronger with time as opposed to cemented component. And less chance of leaving a foreign body. If it's infected, you're taking it out and you're not leaving a piece of cement in there that can lead to recurrence of infection. But again, this has not borne out in literature. But again, most people would look at it and say, maybe you would give a small advantage towards uncemented component. Now, is it better for the surgeon? Absolutely, any given day. It's much easier to do an uncemented acetabulum than cemented acetabulum. I would argue strongly towards the fact that some uncemented acetabulum gets a plus over there. Now, is it better for the hospital? It may be, maybe not. Again, less OR time will lead to less cost, especially in a high volume center. If it's a low volume center, it may not matter, but in a place where they're pumping out cases, you want more cases. For the hospital, the more cases that are done, the more money they earn. On the other hand, it's a costlier implant than a cemented component, but you got to excess OR time versus the costlier implant might balance out, especially in the setting I'm working at. Is it better for the healthcare? It's probably better if used selectively in younger active persons and use the cemented component in elderly whose life expectancy is less than 10 years, because super elderly people with porotic bone, there might be a higher incidence of failure of uncemented component, especially during implantation with fracture or subsidence. But again, not many of us who do uncemmented components routinely have noticed that, especially if you gain experience in the technique. Now, my choice of a stabler component is determined by ease of use, surgical time, which is significantly lesser with uncemented component for me, modularity and ability to use modular dual mobility bearing surface, my confidence in biologic bond, and here's the most important thing, my absolute lack of experience in cemented acetabulum construct. So my choice of acetabulum component, my implant of choice for most cases is an uncemented component. It is three-dimensional coated, tantalum, tritanium, porocoat, one of those. It's a hemispherical component with cluster holes. I would strongly recommend anyone using uncemented acetabulum component to use a cup with few screw holes at least. Even though you're not going to put the screws in, put the cup with the screw holes in, because if you don't seem to have primary stability, like the previous speaker has said, you can gain that primary stability by putting a couple of screws in. Or if you cause an iatrogenic intrafracture, you can salvage that by putting a couple of screws in. The worst thing that can happen is if you select a cup without screws and you don't have a good enough fixation, and you're not going to waste that cup because that's $3,000, and then you're going to put that cup in a bad way, and that's going to hurt the patient. So I would strongly suggest everyone to use a cluster hole acetabulum component for various reasons. The backside wear and polyethylene osteolysis, especially with the highly cross-linked poly, is a non-issue at this point. The previous generation polys had an issue where there could be a conduit that could cause osteolysis, but the current generation implants don't have that problem. Current generation bearing surface does not have that problem. I always fix all the cups with 2 screws, no matter what. In a revision scenario, I put 4 screws. I bone graft into the other screw holes that might be there to help with the osseointegration. I get the bone graft abundant autograft during surgery from femoral head and also from the femur. I don't see a reason why I should waste it. If it takes 1 minute to fill those screw holes, the empty screw holes with bone graft, thereby, Schmalz-Reed and Harris data shows that majority of the ingrowth in the acetabulum components occurs right around the screw hole. So I'm trying to facilitate that ingrowth there. And I, most of the time, use a dual mobility insert with a ceramic head. Here are my standard components. This is a patient with significant arthritis of the left hip. I use an uncemented component and a single tapered femoral component. I fix the acetabulum with 2 screws. I try to achieve about 40 to 45 degree abduction and about 20 to 30 degree anteversion. I do my hips through mini posterior approach. So my choice in a rare scenario with acetabular bone defects, I'm still sticking with uncemented components in these cases. The real question comes down to, is the femoral head viable or not? If the femoral head is viable, as in a hip dysplasia or a post-acetabular fracture scenario, I will use the femoral head as an augment for the defect. If the femoral head is non-viable, I would use a metal augment, trabecular metal augment, and a hemispherical acetabular component. Now here are the examples. This is a lady who had severe protrusion of the acetabulum. Her femoral head, even though was not that particularly good, she had good bone stock in the metaphyseal area. So I used an uncemented acetabular component aiming for a peripheral fixation on the rim, fixed it with coupled screws. I think I put the third screw on the back too. And I used the cancellous bone that I obtained from the metaphyseal area to pack behind the cup. It may or may not be that important, that cancellous bone. I'm putting that in there for restoration of the bone stock for future. Now, I used a dual mobility construct in this lady. Another important reason to think about dual mobility construct is patients with stiff spine. Patients with stiff spine, their pelvis does not move when they sit. So when the pelvis does not tilt backward, entire motion is happening at the hip and they tend to lever out from the back, especially in a person who's done through posterior approach. Now, this is a second patient with an acetabular defect I wanted to show, a person with a neglected pelvic fracture with posterior femoral head dislocation and also symphyseal disruption over here. You can see that significant posterior column defect over here, and the hip has been dislocated posteriorly. So this is how we salvaged it. I used a trabecular metal acetabular revision shell along with trabecular metal augment on the posterior superior side to recreate the posterior column. The anti-column over here is intact. We recreated the posterior column and fixed it with a hemispherical cup. Now, the femur, I still selected an uncemented femoral component. The cable was not because I broke the femur. The cable was because I anticipated the femur to break, so I put it in prophylactically. Now, femoral components, we went over extensively with the nature, the type of femoral components. Now, surface finish is a factor, polished, matte versus grit blasted. As Satish said, polished components by far have the best outcomes. Exeter around 1980s or 1990s changed the surface to a matte finish and they had a terrible outcome. They reverted back to smooth finished at that point and they've had excellent results. Grit blasted for femoral components in general is not good. So polished or matte finish in general are the ways, is the way to go. Now also whenever you're doing a femoral cementation, you got to think about, is this stem a stem which will allow me to rotate inside the canal, which is, it's not canal filling stem? Or is this a canal filling stem that will fill up the entire canal where I don't have much chance to change the version? So it's important from a technical perspective to know that difference, because in a stem like Exeter, as Dr. Satish sir has said, you want to put the cemented component in a more of a doughy state as you're inserting it. If you do that for the stem, OmniFit hip fracture stem or OmniFit Eon stem, which is more canal filling, and wait for it to be in a doughy state, you'll have trouble getting that stem down. And that's the worst possible feeling you can have in the OR. So know the differences in the shape, know the differences in the geometry of the stem, and also whether they're canal filling or not, because if it's a canal filling stem and you implant that in a doughy state slowly, at some point it's not going to go any further down. So these are very technique sensitive depending on the geometry of the stem. Now, also they differ based on the presence of collar or not. The stems that work based on taper slip principle don't have the collar, whereas the ones that don't depend on taper slip principle have the collar. And you want to create adequate mantle for cement fixation. Now, the pros and cons, again, anytime you're picking between two techniques, you're looking at the pros and cons of either of those. Now, as far as the femoral component cemented goes, the advantages are it's cheaper. It's got excellent track record and survivorship, especially with polished stem, as good, if not better than uncemented stems. Lower incidence of early failure, fracture, and loosening, especially in the registry data, Australian registry and all the registries show that early failure rate from fracture or loosening is low in a cemented stem. It has infinite modularity. You can change the leg length version any way you want, which means that you have infinite ways of ability to screw it up too. So the more chance you have to change it, the more chance you have to screw it up if you're not paying attention to it. Stress shielding is not a big problem with a cemented stem. And there's less incidence of end of stem pain with the cemented stem. Now, the disadvantages are it's time consuming. It is technically demanding, again, especially with a tape, with a stem like Exeter stem, where you can change the version, leg length with Exeter because there's no collar involved. You can actually overdo it and put it down the canal. So you got to pay real attention to detail whenever you're doing a stem like Exeter. It's more technically demanding than a fracture stem, which is more canal filling. Cardiac issues have been noted, especially when you don't pay attention to sucking the canal distal to the cement. You know, air embolism is an issue. Sudden cardiac deaths have been reported, especially with cemented stems more than uncemented stems. Now, if the cemented stem gets infected, you know, the chances of you being able to get a well-done cemented stem out completely along with the entire cement mantle is it's very difficult to get it out without doing an extended throat osteotomy. Even in that case, you're worried about the retained cement that can cause recurrent infection. And non-biologic fixation, and especially if somebody does not do a great job at cementation, failure can occur over a period of time. Now, this chart was shown, the classification by Mont and Paul Kanuja from Baltimore, about various types of stems that are there. There are various geometries of the stem. A single tapered stem is the type 1, where there's only taper in one plane. Dual tapered stem used to be my standard stem before I adapted to single tapered stem once we figured out how to appropriatize the biomechanics. Now, also, there are also modular stems, anatomic stems. Again, femoral side is basically dealer's choice, whether you're thinking about cemented or uncemented. If you know the stem well, that you can use for majority of the cases, I would recommend you stick with that stem that you know the most and try to figure out certain instances where that stem won't work and figure out what stems can you use as a salvage. Now, most of the stems have, just like the cemented Exeter stems, have somewhere between 95 to 100% survivorship on long-term follow-up studies. Now, the pros and cons of uncemented stems. It's easy, technically less demanding, less OR time. Again, cost savings involved with the OR time. Even if you save 10 minutes there, at least in our place, it's a lot of money there. It is more forgiving than uncemented stems in most people's hands, especially if it's not one of those door C femurs. Biologic bond hopefully strengthens with time. That's kind of an assumption. Excellent long-term survivorship has been reported with uncemented stems. There's less concern of a retained foreign body during removal for infection. So you don't have any cement distally, so you're not worried about, as long as you take the stem out, you know that there's no foreign material there. I'm not saying that taking out these uncemented stems is easier. What I'm saying is that once you have taken the stem out, you're less concerned about retained foreign body or foreign material. And there's less incidence of cardiac issues than in the cemented stem. Now, the downsides of uncemented stems are cost. Some of these stems can be expensive, but you can offset the cost with the volume. So as long as you have a deal with the vendor where you talk to them and say, we're gonna use your implant for most of the cases, usually most of these companies will give you a rebate. So you can cut down the cost that way. There's a higher early failure rate, especially in older patients with thin porotic bone and type C femurs, the dorsal femur that Dr. Rajkumar showed. Stress shielding is an issue, especially in a fully coated stem. Usually, version cannot be changed. Most of the uncemented stems that we use in a primary scenario are proximally coated, proximally canal filling stems. So when you have a proximally coated stem that goes in a certain way that gains purchase in the proximal femur, there's only a little you can do to change the natural version of the femur, unless you use a modular stem. So usually, version is fixed. It is difficult to remove, especially in a fully porous coated stem. Again, as I said, in a case of infection, you're less concerned about leaving the foreign body in there. But removal may not be easy with an uncemented stem, especially in the fully coated stem, where you may have to do an ETO, cut the stem, use a tree fine to, core out the distal stem. And that might be an R to R&A project, taking out burning 3 or 4 burrs and throwing a lot of F-bombs in there in the OR. End of stem pain has been reported with uncemented stems with an incidence of 1 to 35%, depending on the nature of the stem that we use. Now, the questions to ask, again, when you're talking about uncemented femur versus cemented femoral component, is it better for the patient? It's a wash. It may or may not be. Most uncemented and cemented stems do great. It's comparable in most patients. The uncemented stems may actually be inferior in porotic bones and dorsifemurs. However, in an older patient with a porotic bone, it may have less cardiac toxicity or cardiac morbidity. Now, is it better for the surgeon? Yes, I think it is, because it's easier to do. There are less futzing around in a regular case that you do where you don't need to change the version, leg length. In a complex case, yeah, you can think about it. Majority of the cases, we want to keep it simple and stupid. So it's easier to do because you have less ability to screw this up than a cemented component like an exit stem. So it does definitely save time. Now, is it better for the hospital? Again, it's a wash. Increased cost versus increased OR time, decreased OR time, where you can offset the cost by saving the time in the OR. And the ability to do more cases, which will generate more revenue for the hospital. Is it better for the healthcare? I think it's better if it's done selectively. So if somebody, from a healthcare perspective, from the entire country perspective, I think it's better if you do uncemented in a younger person and cemented components in elderly with porotic bone and dorsifemur, so that early failure rate is lower. So that's kind of the thought process when you're selecting uncemented versus cemented component. My choice of femoral component depends on bone quality, door classification of the femur, whether it's door A, door B, or door C, depending on how wide the canal is or the geometry of the femur. If the patient has altered proximal geometry, in certain cases, we're going to go over some cases. And if there is a need to adjust leg length version, or if I need to do an osteotomy in certain cases. So these are all the factors that my selection of the femoral component depends on. In most of the cases, I'm using uncemented, proximally coated, single tapered stem. Again, I would recommend everyone to pick one stem that works consistently well in their hands so that their OR time is minimized because they got their routine established. And figure out situations where that regular stem that you do will not work, and pick the other stems for those scenarios. So those scenarios for me include patients with poor bone stock. So the single tapered accolade stem won't work for me in a patient with a poor bone stock, especially in femoral neck fractures and osteoarthrosis in elderly. So for femoral neck fractures and osteoarthritis in elderly patients with thin porotic bones and dorsifemurs, I tend to use a more canal filling matte finish stem because it's easier to do more than exeter stem. And the survivorship, 2 decade survivorship is pretty darn good. May not be as high as exeter, but it will get them through 15 to 20 years. If I see a patient, and it's also cheaper too compared to exeter. If I see a patient with osteoarthrosis in a relatively younger patient with a dorsifemur, I do a cemented collarless polished tapered stem like an exeter stem, which by far has the best track record. In patients that need version, leg length adjustment, or patients who need osteotomy, I tend to use 2 different types of stems. One is a proximally fixed stem with distal modularity, which is an SRAM stem, where there's a proximal fixation, and the stem that goes into the distal canal can be rotated any way. So it's a proximal fixed distal modularity stem. Or the second type of stem is distally fixed proximal modular stem, which is link or restoration modular, which gains fixation distally, whereas there's a modular proximal component that goes on the distal component that you can use to change the version. Or in an extremely rare scenario, I use a fully porous coated AML stem. In these cases, it will work too because AML gains fixation distally, and the proximal geometry of AML is not necessarily canal filling. Now, these are my standard components as I showed. I use a standard accolade single tapered stem for majority of my cases. Now, this is a patient, 59-year-old. I did this lady last week. She had an interthroat fracture that was fixed by my partner, and she convinced him to take that femoral stem out, the short gamma nail out, because she had a protruding screw. And a month after he took out the hardware, she suffered this femoral neck fracture. She obviously has really bad bone quality. It's a dorsifemur, thin cortices, uncemented component in this scenario. You know, I'm thinking about causing perioperative periprosthetic fractures and problems. So I chose to do an Exeter stem because she was younger. She had longer life expectancy. So I used an Exeter stem and bypassed the distal locking screw. Now, this is a lady who came from Iraq, bilateral pro-4 dislocated hips. She needed a subtroch osteotomy, so we did an SRAM stem and did a subtroch osteotomy and had basically proximal and distal fixation. This is a lady who has dysplastic hip. In a patient with dysplastic hip, again, as we went over before in the previous talk, patients have coxa valga, patients have leg length discrepancy, patient also has increased anteversion. So you need a stem that will allow you to correct all of them. So we picked an SRAM stem, which works very well in this type of scenario. This is a patient with altered proximal geometry. There's no way you can get a proximally fitted stem here. One could consider doing a cemented stem, but the cemented stem, as it goes distally, the majority of the stability of the cemented stem depends on the trapezoidal shape with the rounded surfaces in the proximal canal, in the oval shaped proximal femoral geometry. As you go distally into the canal becomes more circular. Circular cement in circle doesn't give great fixation. So this is a type of scenario where there's no proximal medial bone left. An uncemented component is probably better. A proximally coated component won't work. So the quickest way to deal with this is, the canal size is good enough. So a tapered fluted modular stem, you're done in 5 to 10 minutes and you're over with. This won't take too long. This is a time-saving procedure. This is a patient who had a Southwick osteotomy when he was a kid for slip capital femoral epiphysis and came to me with this secondary degenerative arthritis. He was a 46-year-old patient who had this problem. So we went ahead and used again the tapered fluted modular stem, distal fixation, proximal modularity. Now the distally fixed modular stems are useful for revisions, especially where you can adjust the leg length, version, and you have ability. It makes the surgery a lot more easier. The taper gives you the axial stability, the flutes give the rotational stability, and the modularity optimizes the biomechanics. So there are various tapered fluted modular stems that are available. Very rarely I use these in a primary scenario. Now, before I finish up on the final note, I want to alert some problems with uncemented components too. I don't want to sound too bullish on uncemented components. Stress shielding is an issue in the acetabulum. This is a patient who had a metal-on-metal toe-lip arthroplasty done by a surgeon in the community. This is something you will notice if you look at the superior aspect of the acetabulum. It seems like osteolysis. This is not osteolysis. That's stress shielding of the acetabulum. Most of this uncemented cups have peripheral fixation. Even if it's hemispherical cups, a lot of people don't ream line to line. They under ream by 1 millimeter or 2. The cup does not bottom out, especially in an elliptical cup. And what will happen is that the fixation is mostly in the peripheral part over here, if you can see it. And the central part behind the cup is stress shielded. Some of these people over a period of several years, the bone behind the cup becomes very porotic, especially in a metal-on-metal hip where the cup is cobalt chrome. So this lady was a dislocator. So the guy who did it attempted to revise the cup to metal on poly with uncemented cup. He had to revise the cup. Obviously, he ran into trouble there with reaming superiorly into the stress shielded acetabulum. So he superiorized and malpositioned the component. So he referred her to me, and when we went back in there and she loosened the cup, obviously she fell down and broke the posterior column, and she had to need this monstrosity to get her out of the OR, including a posterior column augment, another augment, and a posterior column plate buttressing it. So uncemented cups are not without problems in long term, especially if you have to revise it. Some of these patients can have a bad stress shielding behind the sternum. Stress shielding of an AML stem has also been reported extensively in literature. Over a period of time, the proximal bone, which does not see stress, gets evaporated. And some of these people, especially when you go to take that stem out for infection, you don't have any bone left at that point. In summary of the literature, I reviewed the literature for uncemented and cemented fixation. There's definitely less OR time and ease of use with uncemented fixation. Lower cost of implant and lower incidence of early failure with cemented fixation. That's coming mostly from registry data. And I would believe it, especially if you do uncemented fixation indiscriminately in porotic bone, there will be slightly higher early failure rate. The value of biologic bond, as much as it's talked about in uncemented fixation, is not clearly established in literature. Part of that could be because of the heterogeneous nature of uncemented components. Now, uncemented components, as has been spoken by the previous speaker, have evolved through multiple generations. When you're looking at this literature, when they pile up multiple groups over a period of time, that includes good uncemented components and bad uncemented components, whereas cemented fixation has kind of remained the same for a long time at this point. And it was also the first to evolve, so it has an advantage. So I just want to put that out there, that the value of biologic bond, even though we believe it, has not been clearly established in literature. Uncemented acetabular components might be slightly favored in acetabular, on the acetabular side especially, might be slightly favored in long-term survivorship. However, femoral component survivorship is a wash. They're basically comparable. You pick the femoral component that you like and that works well in your hands. Now, parting thoughts. The choice of implant fixation, cemented versus uncemented, is not as important in a hip replacement as bearing surface selection, which has a bigger impact in determining the outcome, technical expertise of surgeon, and cup positioning, which is where most of the thought process seems to be going to lately. Never forget that what works best in your hands and in your setting is probably best for your patient at that point. Always ask essential questions. Why, what, when, before you make a change. And be open to new technology and techniques while critically evaluating their value. Now, I would leave you guys with the final thought from Bill Gates. He said, I choose a lazy person to do a hard job because a lazy person will find an easy way to do it. Thank you.
That's a wonderful talk. Thank you very much, Dr. Sridhar. So I got some clarity over cemented and uncemented now. So hope it is same with all the other participants. So one request to all participants, you can choose to write your questions in question box of YouTube link. We have a slide change in the next talk. Dr. Mahesh is going to talk on a concept of offset, version, and soft tissue balance in THA, as he has to leave for some commitment. So over to you, Dr. Mahesh.
Yeah, thank you, Srinivas. I'm going to quickly whiz through this presentation as I think we are already running a little bit late. We're going to talk about surgical technique now, about how to look after version, offset, and soft tissue balancing during the surgery itself. So the three technical important aims are restoration of center of rotation of the socket, restoration of the medial offset, as well as the vertical offset whenever you are performing a hip replacement. So the center of rotation of the socket, when you template, as Dr. Rajkumar has excellently demonstrated, when you template your socket, you mark the center of rotation according to the position of the teardrop. The restoration of offset is crucial as well. The medial offset is measured from the center of the femoral head to the axis passing through the center of the femoral canal or the stem itself. And then you have to restore the distance between the center of the femoral head and the lesser trochanter. So all of these things, when you restore them, will give you stability of the hip joint, maintaining adequate soft tissue tension. The templating has been explained very well by Dr. Rajkumar. I need not go into details of it, but basically what you need to understand is what was the preoperative shortening on that side, measure the center of the rotation of the cup, mark it, make sure that you lay upon the femoral template and see how much lengthening are you going to achieve at the end of the procedure. And if you don't want any, you need to adjust your neck cut accordingly. So while determining the variety of parameters that we mentioned, the first thing I will look for is version and alignment of the acetabulum, followed by the stem. Check for offset, check for ling length, and also make sure that you achieved good stability of the hip joint in the end. So to make sure that you get your version correct, make sure that you position the patient yourself, or at least have a look at the position of the patient. Make sure you have supports onto the anterior aspect so that the patient doesn't fall off from the true lateral position. So do that and make sure that you have actually observed it. Exposure is critical. Make sure that you get good exposure, 360-degree exposure of the acetabulum. This is superior, this is inferior. I position one Hohmann retractor anterior to the tal, one Hohmann retractor posterior to the tal, so that if you start reaming in between these two Hohmanns, your version is pretty much sorted according to the tal, and also get the inclination right dependent on the tal and also the position of the handle, which I'll show you through a small video. Get to the floor of the acetabulum, and this paper by Dick Beaverland et al. Is very crucial. So if you identify your tal, you can see if your component is too high, if there is a gap inferiorly, whether the cup is too anteverted or retroverted, depending on the alignment of the cup to the tal, and also whether the cup is too deep. If you see that the tal is pretty proud, that means you have medialized with the cup to a significant extent. Now the limb length, after you get your version and inclination right, you need to concentrate on the limb length. You can do it either by a caliper method using two fixed points on ilium and greater trochanter and measure the distance between these 2 points before and after insertion of the components. However, the drawbacks are the points are pretty much away from the center of rotation of the hip joint, so the errors can be magnified, and position of the leg will also create potential for the error itself. The shuck test, not many people like it. I still do it. I do a lateral pull as well as a downward pull. The lateral pull will give you a fair idea of the offset, medial offset, and the downward pull will give you a fair idea of the length, limb length as well. Palpation of the knee and the malleoli during surgery is another crude method of understanding the limb length as well. So the approach is going to be covered by Dr. Raju. So I'll move on and I will just show you the way I position my retractors to get my version right. So basically, once this is an ankylosed hip, so we've done an in situ osteotomy and then placed a Hohmann anterior and posterior when I got my reaming done. The version of the femoral stem, you can't really manipulate a lot when you're using uncemented stem. It will be dependent not only on the lesser trochanter, I rely more on the position of the leg. So the position of the leg and the distal femoral condyles, I would antevert the component by around 15 degrees, but you can't really change much, as I've said, in an uncemented stem. Once you've done the reduction, let me just show, check the length, get the heels together, check the length of the knee itself. I will do also a lateral pull test to see if there is laxity and take the hip through a range of motion. So this is the level where you check the leg length, whether you achieved it or not. Make sure that you have checked it preoperatively as well. Otherwise, use the technique, which is very good, is described by Harish Bhende and Dr. Ranawat. I use the infracotyloid fossa to insert a Steinmann pin and make a mark before you dislocate the hip joint, make a mark over the trochanter. And on the preoperative template, you should have checked how much of shortening was there in that native hip. Once you put the trial components, reintroduce the pin and check how much of lengthening you have achieved and whether that is within the distance that you had calculated preoperatively. So I think this technique is pretty good. It will give you good soft tissue tension with the limb length. And the offset you should have calculated on the preoperative template as well. And then you can recreate the offset by using the chart that has been provided by the company to see how much is the built-in offset of the stem itself. The Steinmann pin technique has good simplicity, accuracy and predictability. And because it is which is in close proximity to the center of the rotation of the hip joint, the chances of errors are reduced as well. However, learning curve is a little bit long. Inaccurate pin placement or inadequate pin placement can cause problems, or the leg position can cause problems with the Steinmann pin technique as well. If you feel that you need a longer offset, you always should demand with your company rep to bring in both offsets. Now, some of the companies will change the increased offset is by changing the neck shaft angle, and this will affect the leg length and may lead to abductor insufficiency. But some of the companies will provide you with an increased offset by just medialization of the neck. Here are a couple of examples. This is the ML taper step. The offset increases by increasing the parallel neck shift, which allows you to increase the medial offset without changing the neck length. However, if you change the angle of the offset, then the limb length will be different, and you need to be careful of balancing the joint. Couple of tests that I do is the coplanar test to make sure that the alignment of the version is right. So you make sure that you get the head edge of the head parallel to edge of the cup, not to the poly, because the poly might have an elevated rim if it's a lip liner. And then once you make sure that the edges of the cup and the head are parallel, you see what is the angle of the leg which is made to the floor. That's going to be your combined anti-version or a coplanar test. And finally, I will take the hip through a range of motion. So I will get the hip in extension and external rotation, and also adduct and get it into external rotation to make sure it doesn't dislocate anteriorly. Then take the hip through a sleep position where the patient is going to lie in his bed, and make sure that the hip flicks to 90 degrees and adduct and internally rotate to make sure that the hip remains stable throughout the range of motion. So in all, what we've seen is we've talked about version, the way you get your version right intraoperatively, relying on the TAL, position of the Hohmann retractors to define the TAL, positioning the patient correctly so that you can get your version right. I'm not going to go into spinopelvic problems which lead to alteration of version. That will be too much. The second thing is get your offset right. You should have calculated the offset on the native hip preoperatively. Try and recreate that offset by using the neck cut which you've defined, as well as the measurements before you have made the neck cut compared with the trial implants. Recreate it. The shuck test is not a very reliable test. I tend to do it just for completion's sake. Finally, take the make sure that you get the limb length right by using one of the methods. The Steinmann pin technique probably is the best, and take the hip through the range of motion before you close the hip joint. Thank you very much. Srinivas, thank you very much for the opportunity. And once Srinivas is live, we can pass on the burden of the next talk with Dr. Krishna Kiran, who's very kind enough to let me finish my talk.
Thank you so much, Dr. Mahesh. There is one question for you.
Yeah.
So can you just elaborate on coplanarity?
Yeah, so the coplanar test is done. You can do it at the time of trial component insertion to make sure absolutely that your version is right. So you keep the leg in neutral position, so no abduction, adduction. And then let me see if I can go back to the previous slide. Let me see. So get the edge of the head parallel to the edge of the cup itself. So to bring the edge of the head parallel to the edge of the cup, you need to antivert the hip or turn the leg into internal rotation. So the amount of angle the leg forms with the floor is the amount of combined antiversion of the stem and the cup. which should be approximately 35 to 40 degrees in a neutral position of the leg. So that will give you an idea about what is the combined anteversion, which is also known as a coplanar test. Coplanar is you get the head edge and the cup edge in the same plane. To bring it in the same plane, you need to move the leg in a little bit of internal rotation as compared to floor, which is taken as a landmark, and the angle between those two is the combined anteversion angle.
Thank you so much. With that, we'll go ahead with the next part of the talk by Dr. Krishna Kiran on bearing surfaces, how to choose. So over to you, Dr. Krishna Kiran.
Yeah, sure. Anytime for you, Mahesh. Great initiative, Srinivas, as always. Great to see Sridhar after so many years. We studied together almost 30 years back now. So amazing to catch up with old friends. Yeah. So my brief is to talk about bearing options in total hip arthroplasty and see some tribological principles and look at them to make a decision. So we all know that the normal bearing is an articular cartilage, and now cartilage is a compliant bearing with low modulus of elasticity, and it has an ability to resist high deformation forces. So unless there is a hip dysplasia or alteration because of trauma, the incidence of hip arthritis is lesser as compared to knee arthritis. So it's an important point we must keep in mind. The low coefficient of friction is achieved by three lubrication methods inside a normal hip joint. It is different in the swing phase and stance phase. So you have a combination of electrohydrodynamic and microelectrodynamic mechanisms in the swing phase and a squeeze film lubrication in the stance phase. So I will elaborate a little bit on the lubrication mechanisms as we go along. So now the concept is of fluid film lubrication. So when you have two opposing surfaces in contact with each other, there is a fluid film which separates the two surfaces out, then that is the ideal situation, because then there will not be any contact between the two opposing surfaces and there is no question of wear happening. So that is what we are trying to achieve with a prosthetic joint replacement. Unfortunately, it's not yet there where you can achieve fluid film lubrication in all the situation. An ideal bearing should have low wear. It should have no immune response to generated debris. You must be able to use a sufficiently large head. There must be low friction to minimize implant bone and head taper forces. So you should not have implant loosening and stress shielding. You should not have trunnionitis issues. It should not produce any noise. It must be chemically stable in vivo. And we had the zirconium experiment, which failed badly because there was a phenomenon called as phase transformation, where the zirconia underwent phase transformation and fractured at 7-8 years following the implantation. So although the early results were good, the implant, because it had phase transformation and was chemically unstable inside the body, it had higher failure. So we don't want such experiments to happen again. The implant should not fracture, as we have seen with certain ceramic bearings. You must have resistance to abrasion. That means if you have a third body or some sort of a non-ideal scenario which happens all the time inside the body, it still should be resistant to that abrasion. Now, when we look at the tribology of bearing surfaces, you must have a working knowledge of the two concepts of friction and coefficient of friction. So it is sufficient to say here that if you have the picture on the left side, you have two surfaces in contact with each other, and what you assume is that the entire surface is in contact with each other. But what actually happens in reality is there are micro asperities on each surface, and the actual contact area is equivalent to the highest asperities which are there on either of the surfaces. So this is where we all know that as the surface area increases, the contact stresses will come down. But in real life scenario, the actual contact area is very less because of surface roughness and micro asperities which are there on the opposing surfaces. Therefore, there can be a higher risk of wear happening unless there is a fluid film which is interposed between these opposing surfaces, which is thicker than the highest asperity on each surface. By that, I mean the lambda number. So the lambda ratio is the thickness of the fluid film. should be greater than 3. That indicates that it is higher than the largest asperity on the opposing surfaces. So if you have a femoral head, say a metal head with a 3 microns asperity on its surface peak, which is in contact with the polyethylene, then the surface area is so low that it will remove polyethylene over a period of time. But if you have a fluid film which separates these throughout the swing and stance phases, then the wear rates are lower. So you have 3 types of lubrication. In an ideal scenario, you'll have what is called as a fluid film lubrication, where throughout the walking phase, standing phase, you will have a full thickness fluid film which is separating the 2 opposing surfaces, the femoral head from the acetabular cartilage. That is the normal situation. The in vivo scenario where we have a hip replacement in place will have varying phenomenon, and that is measured by the Strybeck chart, and it's measured by a number called as the Sommerfeld number. As you approach 1, you will have fluid film lubrication, which happens with hard on hard bearings, so ceramic on ceramic, metal on metal with large diameter heads. There is a fluid film which is possible, so the wear rates in these bearings will be lower. But if you have a metal and poly type of articulation, we have patterns of mixed and boundary lubrication, where there is an incomplete or an absent fluid film between the opposing surfaces. And if you remember, I told you the entire surface is not actually in contact. It's only the asperities which are in contact. So this particular principle must be borne in mind when we make a choice of the bearing. The other important tribological principle which we must have in mind is the various methods of wear which are there. So you have 4 primary wear modalities. You have the adhesive wear, which happens between the primary bearing material. So if you have a metal head articulating with a polyethylene, the harder surface will preferentially remove part of the softer surface. That is, will happen with weight bearing all the time. The other thing which can happen is when there is a slight subluxation of the hip, which always happens. So whenever there is a transition from a swing phase to a stance phase, or a stance phase to a swing phase, there is micro separation of the hip, and this behavior of the bearing surface during micro separation is an important consideration while choosing the bearing surface. The second is third body wear or abrasive wear, which we talked about, when you have some particles like bone pieces or metallic pieces inside the articulation. So you have the hip replacement with some sort of a third body or abrasion, or if you have scratched the head, say while you're trying to insert the head inside, there will be a lot of asperities on the surface of the head, which will create abrasive wear between the polyethylene and the head or the articulation. The last type of wear is the wear which is not intended, which happens between the secondary articulation, which are, suppose the hip dislocates, then the neck is impinging on the periphery of the cup, or you have the wear between the polyethylene liner and the backside of the socket, which is called as the backside wear. So these are the non-primary articulation. The primary articulation is likely to be between the femoral head and the polyethylene liner or whatever insert we are using. But the secondary articulations between the polyethylene liner and the cup, which is a backside wear, or in cases of impingement between the neck and the cup, which are not intended to be the primary modes of articulation, is the ones which give rise to the secondary wear. So the factors to consider while choosing bearing materials: you must choose the bearing material with the best corrosion resistance, hardness, ductility, surface roughness, strength, and scratch resistance. So here ceramic scores over cobalt chrome. So you look at the, if you have a scratch on ceramic, it will be like a trough there. But if you have a scratch on a cobalt chrome head, you will have 2 peaks and a trough. So the asperities and the surface roughness will increase, with thereby increasing the abrasive wear of this material. So currently, the standard of care is to use a ceramic head wherever it is possible. And when we look at why hips fail, it has been recognized that one of the leading causes of implant failure in total hip arthroplasty is aseptic loosening due to osteolysis. So aseptic loosening occurs because of chronic inflammatory response to the implant derived wear debris. So we have seen various mechanisms of wear which are possible, and these debris, if they are small enough, if they are biologically active enough, they will lead to an inflammatory response through T cells and lead to subsequent bone resorption, which is caused osteolysis, and it's an aseptic phenomenon. And this is how an osteolytic lesion looks like, where there is global osteolysis following a cemented cup failure. and where there is a uncemented cup failure because of progressive polyethylene wear, you can see the eccentric positioning of the femoral head inside the cup. That is a way to determine the presence of polyethylene wear. And you can see at the behind the cup, there are large osteolytic segments because of the wear particle induced bone resorption. Now the wear particles will have a specific biological activity, and there are several millions of particles which are there inside every hip joint. All of them do not give rise to osteolysis. So the two consideration of bearing couple are what is the volume of debris that is produced and what is the specific biological activity of the wear particle. So you have head size considerations here. If you have a 22 millimeter head, then the 22 millimeter head will have a lesser surface area for contact. So the volumetric wear will be lesser, but linear wear will be higher. But if you have a 36 head, the volumetric wear will be higher and the linear wear will be lesser. So that is a concept again which you must understand in depth. And there is a relationship of wear rate and osteolysis. Literature review has shown that osteolysis is rarely observed at a wear rate of less than 100 microns per year. So that is the osteolysis threshold for a hip. And a 25-year survivorship of processes has been observed where the wear rate is less than 100 microns per year. This is with the Charnley hips, but the wear exceeds more than 200 microns per year, then the 20-year survivorship of the processes was below 30%. So this is a very important concept. So it is important to position your implants very well, to have better bearing couples, to have the optimal head size and optimal thickness of the polyethylene in order to minimize this osteolysis threshold that is seen with the polyethylene particles. Now, the modern polyethylene is the cross-linked polyethylene. It has eliminated a lot of problems related to the conventional polyethylene where there is osteolysis related to the polyethylene wear particles. So we do not use any conventional polyethylene in modern total hip arthroplasty. And the cross-linked poly is obtained by cross-linking of the conventional polyethylene. And this was an anecdotal or an accidental discovery which happened when they found that when they were sterilizing with gamma radiation, there was some element of cross-linking which was happening, and this had a protective phenomenon on the wear rates. So the important consideration here is the radiation dosage. So you have moderately cross-linked polys where the radiation dose is between 5 and 7.5 megarads. And if you have more than 7.5 and up to 10, then you have a highly cross-linked polyethylene which is available. And most of the implant companies have highly cross-linked polyethylene now, and this is a standard of care in you choosing a polyethylene bearing in total hip arthroplasty. Now, based on the post-radiation thermal processing, you have two types of cross-linked polys. One which can be annealed, where the polyethylene is melted, annealed is melting, the heated below the melting point, and remelted where the heating is done beyond the melting point. So this is the post-radiation thermal processing. The problem with cross-linking is the mechanical properties are somewhat compromised. So if you have an annealed polyethylene, you have more free radicals which are not taken care because you have not melted that polyethylene. But if you have a remelted polyethylene, there is less free radicals, better wear properties, but the fatigue resistance of that particular polyethylene is slightly lower than an annealed poly. So whenever you're choosing a cross-linked poly, you must look at the radiation dosage which has been used, what was the post-radiation thermal processing to take care of the free radical problem or oxidative damage which can happen with keeping that polyethylene on shelf for a longer period of time. Now, different methods have been tried to manage the free radical problem. One particular experiment was with the vitamin E poly. It's been introduced since 2011, but we do not have long-term data. But it is promising. It shows that the vitamin E, which is a naturally occurring antioxidant, it is diffused onto the polyethylene, and it minimizes the post-sterilization oxidation without weakening the polyethylene. Now, the most important is the studies. The wear with XLPE has been shown that across all head sizes, there is a reduction in linear and volumetric wear. You can reduce the minimum thickness of polyethylene to 3.9 millimeter without compromising wear. For reasons of strength, however, we must choose a poly which is between 5 to 6 millimeter minimum thickness in order to avoid a fatigue type of fracture. In young patients, 10-year follow-up, cross-linked polyethylene has performed exceptionally well with a 100% survivorship. And this is now the standard of care. And there are n number of papers and data from Australian registries going up to 15 years, if I'm not wrong, showing a very good data for highly cross-linked polyethylene. Now you have alternate bearings. We've seen that metal on poly is out. Cross-linked poly is probably the one on the establer side, which we will choose. Metal on metal has come and gone. Ceramic on cross-linked poly is probably our bearing of choice. And we have options of ceramic on ceramic, which is the hard on hard bearing, which has persisted predominantly because the wear rates are less than 1 micron per year. So if you can see, cross-linked poly has brought down your wear rates to 20 microns per year or lesser. So you have almost eliminated the risk of osteolysis, because as we remember, the osteolysis happens when the wear is 200 microns per year or more, and not when the wear is less than 100 microns per year. The last thing which we must consider is wear in adverse conditions. We must look at how the bearing performs if the head is damaged, if you have third body, if there is micro separation and edge loading, which is a constant feature inside the body. And here the XLPE shows worse performance than conventional poly. And I would recommend that it is sensible to use ceramic heads whenever we are using XLPE, because as we have seen, the head damage and the micro asperities are higher for cobalt chrome heads as compared to XLPE. However, there is no data which says that XLPE on cobalt chrome is inferior to that of ceramic with XLPE in the literature. The biologic response to wear of different bearings, the cross-linking will reduce the production of particles, but there may be some smaller particles which are less than 0.5 microns with greater osteolytic potential. This has not been borne on in 15 years, but we must see in the future. In general, the superior volumetric wear properties of XLPE offsets the higher biological activity of the particles. The ceramic on ceramic can have bimodal wear particle distribution, but it doesn't have any biological response because the T particles don't act. The metal on metal has got predominant alval type of response. It's a type 4 hypersensitivity response. It's a T cell mediated response and leads to significant tissue damage in certain situations. Several studies on cross-linked polyethylene showing good results. Metal on metal is not used because of problems related to metallosis, to trunnianosis, to alval. So this is largely gone out of favor. We need to see if the resurfacing makes a comeback through ceramic on ceramic type of bearing. For metal on metal, patients who have already got it, you must have an annual surveillance for them for 5 years. And patients with elevated cobalt and chromium levels more than 7 micrograms per deciliter, you must do a Mars sequence MRI and do a surveillance every 6 months in these patients. And some of them where the levels are more than 100 and the levels are rising, you may need to do a revision surgery. The last part of this talk is on ceramic on ceramic. We've seen that the ceramic on ceramics is a very attractive option in young patients because of very low wear rates. But there are most of the long-term studies are with Biolox Forte, which is aluminum ceramic, and sudden catastrophic failure has been reported with Biolox Forte. So a lot of people are skeptical using ceramic bearing. And as I told you, we had bad experience with zirconia composite. But the Biolox Delta, which is an aluminous zirconia composite with strontium aluminate, has been shown to have good outcomes in the laboratory. Adverse condition testing showed no measurable difference in strength or roughness at a simulated 40 years. That is, they put a lot of debris into the articulation and moved it through several millions of cycles and found that this particular articulation showed very good properties with respect to the wear. And the aluminum zirconium composite with strontium aluminate, which is the Biolox Delta, has been shown to have very good fracture resistance as well. So the risk of fracture is lower. The only way you can fracture it is if you insert the liner, malseat the liner and impact it into the acetabulum, it will break on table. That's the way the liner can fracture. So you have concerns with ceramic on ceramic. They're vulnerable to point loading, especially if there is micro separation and edge loading because of component malposition. Clean assembly is very important. So you must have bloodless assembly of both the liner and the femoral head onto the trunnion, which may or may not be always possible intraoperatively. If you eccentrically insert the liner, it will break. So you must be careful when you're inserting it. And there are two types of liner tapers which are available. One is a 10-degree taper, another is the 18-degree taper. The 10 degree is relatively easier to insert. But if we are using an 18-degree taper like the Johnson & Johnson taper, one need to be extra careful while inserting it, because if there is a tendency to eccentrically insert this liner, and that can lead to liner chipping and fracture. The revision can be a concern with ceramic on ceramic, because the ideal revision would be to another ceramic on ceramic, because if you put in a metal on polyethylene and the ceramic debris is left inside the synovium, then it will eat away onto the metal head. The effects of microseparation, as I told, must be considered. It has no effect on hard on soft bearings, but it has got effects on hard bearings. So that's what happens if you have microseparation where the head comes out and hits onto the edge of the cup, then there will be what is called a stripe wear of the ceramic, and this can be noise producing. Squeaking is another concern with ceramic on ceramic, and that's the noise. You can hear the noise. So it generally indicates that there is some serious problem. In rare cases, that there is a fracture of the ceramic liner. So when they analyzed the incidence of squeaking, it was 4.2%, and incidence of revision for squeaking was 0.2%. So this must be explained to the patient if we are considering a ceramic on ceramic. We must not use the accolade femoral stem when we are doing a ceramic, because the incidence of squeaking is almost twice as high, and the incidence of revision is 10-fold higher as compared to other stems. So because there is difficulty in assembling the liner in a bloodless field intraoperatively inside the surgery, there was this concept of modular or pre-assembled liners like the Delta Motion and the one from Maxera from Zimmer and the Asculap cup. But even this did not reduce the incidence of squeaking, and this paper shows that the Delta Motion hip bearing has an incidence of almost 13% of squeaking with the ceramic. And lack of lubrication can also be a concern with the ceramic on ceramic bearing. The take-home message: the perfect bearing is still elusive. XLPE with ceramic head 28 or 32 millimeter, which allows an adequate thickness of polyethylene, seems to be the workhorse and a reasonable alternative for majority of patients. Ceramic on ceramic advantages could outweigh the risk of noise and fracture in young patients, but you must pay attention to the surgical technique and component positioning if you choose this bearing. Metal on metal and ceramic on metal have largely fallen out of favor. Thank you.
Thank you so much, Dr. Krishna Kiran, for enlightening about the science behind bearing surfaces. So it's not just MOM, it's not C on C or C on cross-link poly, but we should know the science behind the surface to choose the right. Thank you. So let us move on to the next talk by Dr. Somashekar sir about the approaches. The first one would be Harding's approach by Dr. Somashekar Reddy. Sir, over to you, sir. So you're on mute, it seems. It seems you're on mute, sir. Sir, please unmute yourself. Can you hear? Can you unmute yourself?
One second.
Can you
Yeah, now
unmute
it got
yourself?
unmuted.
Can you hear me now?
Yeah.
Yes, sir.
Can you hear me? Okay. Okay. Sharing the screen.
Right.
Okay. Can you hear me now?
Yes.
Okay. Good morning. Nice talks we had, and any hip replacement talk is not complete without mentioning the name of Sir John Charnley. And in continuation of 35 years of TCOS, Twin Cities Orthopedic Society tradition, once in a month, Sunday morning talks actually are not complete without our doyen of orthopedic surgery, Professor B.P. Narasimhulu, who has been a great example how sincere he was and leading as an example for all of us to attend the academic meetings. Until his late 80s, he was attending this meeting, and we are all sorry that he is going to be no longer with us participating in these meetings, and we our respects to him. Namaste, sir, wherever you are. Again, coming to the talk. Now, one of the main differences between Professor John Charnley's approach and subsequent approaches is the attention given to the hip joint capsule. He firmly believed that the source of the hip pain is actually a sensitive capsule, and he religiously excised the capsule completely. Actually, he had an instrument called capsule forceps, because capsule being a tough structure, he needed a stronger forceps to hold the capsule so that he can excise it. But the instance of dislocations after his approach may be partly due to lack of capsular support, and other surgeons who developed other approaches subsequently felt that the capsule is a quite strong structure and why should we waste it. And some of the approaches actually try to save most of the capsule, and some approaches have actually excised part of the capsule just to get enough exposure of the acetabulum. Harding approach is an anterolateral approach where part of the anterior capsule is excised when necessary to improve the exposure. There are so many other modifications, and this modified Swiss lateral approach is a complete capsular sparing approach. And when somebody tries to do it in the beginning, may find a bit like tight exposure, but once you get the hang of it, you know you can do it very easily. Now, this was mentioned already. The positioning of the patient is very important, and the surgeon should be aware of the actual position of the patient, because this will have a lot of bearing in the positioning of the acetabular component. Now, again, once we are happy doing one or other approach of the hip, we should be aware of other approaches, and we should have a decent knowledge of other approaches as well. For example, now, even though I am more commonly doing anterolateral approach or one of the modified versions, now if you see this X-ray and the CT scan, you can see a large osteophyte anterior to the hip joint. And if I am doing an anterior approach, I cannot really dislocate the hip anteriorly unless I remove the anterior osteophyte. And if I start excising, there may be less distinction between the osteophyte and the anterior wall of the acetabulum. So we may under remove the anterior wall or over remove the anterior wall. So in these cases, it may be safe to go to the posterior approach. So any surgeon should have some idea of all other approaches, including Charnley's approach, which most of the people are not doing. But the Charnley's approach is still an important aspect when we are converting a IT fracture to a total hip replacement. Now, if you see the overall incision, most of the incisions are centered in the middle of the greater trochanter, anterior posteriorly, almost bang in the middle. And half of the incision is superior to the tip of the trochanter, and half of the incision is inferior to the tip of the trochanter. And most of the incisions are curved proximally posteriorly. That has an important bearing, because most of the anterior approaches, when we are doing the acetabulum and the femur, we actually get the leg into slightly figure of 4 position. If the proximal part of the incision is slightly curved posteriorly, when we get the leg into figure of 4 position, the proximal part of the femur comes out of the wound easily. if the incision is transverse or like in Watson Jones, slightly covered anteriorly, we will struggle actually to reflect the proximal part of the skin and to get the delivery of the proximal femur out of the wound. So that curve, when we actually, even though we feel it is a curve, when we actually flex the hip a little bit, the so-called curved incision will become a straight incision. And the next picture, if you have a mental picture, anybody learning the hip approaches, if you see the next approach, the line diagram, the important structures, the anatomy of tensor fascial aorta, gluteus medius, sartorius, and then of course posteriorly the lateral rotators, where we are going, which approach is going through which plane. If we have this mental picture, we can easily convert one approach to the other approach even after the incision given. For example, the tent approach described by Harish Bende and Professor N.S. Lord, even though the incision is the same, depending on the necessity on the table, they go anteriorly and posteriorly also. For that, we need this sort of the anatomy in our mind. Now, my talk is just mentioning about the approach. So I'm not going into the actual procedure of the total hip replacement. And the first picture here, you can see the marking of the graded trochanter, the actual incision, the proximal curve. And the second picture is showing the exposed tensor fascial aorta and the actual insertion of the tensor fascial aorta below the greater trochanter into the anterior part of the tensor fascial aorta. The tensor fascial aorta or the deep fascia incision starts behind the insertion of the tensor fascial aorta, so that we don't really disturb the tensor fascial aorta in this approach or the posterior approach. And once we incise that one, the third picture, we expose the trochanteric bursa. In anterolateral approach, you can simply elevate it and you can cut it. But if somebody is doing a posterior approach, actually, if we develop a plane into the trochanteric bursa, it is very easy to actually go towards the sciatic nerve, and without much dissection, it's quite easy to find the sciatic nerve so that we can protect it. So in the anterior approach now, once we cut the trochanteric bursa, we can take it off. It will expose the gluteus medius. It's a fan-shaped muscle, and superiorly it is goes vertically from the tip of the trochanter, and anteriorly it is like an oblique course towards the in the direction of the anterior superior iliac spine. Now, we need to identify the thickest part of the gluteus medius tendon, which is inserted into the tip of the trochanter, where you can here you can see the tip of the trochanter here. My cautery mark is showing that the thickest part of the tendon of the gluteus medius, which we do not want to disturb. The fan-shaped insertion anterior to the trochanter is the one where we are interested, and the cautery actually cuts in a semicircular way on the anterior surface of the anterior and lateral surface of the trochanter. We can put our finger below the gluteus medius and minimus tendon, elevate it, so that while cauterizing or incising the gluteus medius tendon, we can elevate it. Once we started elevating this tendon, only named vessel of this approach is the branch of the transverse branch of the lateral circumflex artery. That's the only named vessel which we encounter in this approach, which can be cauterized. So there are no other major bleeders in this approach. Relatively, it gives us a bloodless field. Once we sort of lift the gluteus medius and minimus flap, that will expose the capsule. Once we have the capsule is covered with a degree of fat, and if we wrap a Gamgee pad into the tip of the either bristow or a periosteal elevator, we can erase the fat of the capsule. So this is the capsule which is exposed there bare. Now, once we have that capsule exposed, we can make a inverted T incision. The vertical limb of the T is from the anterior wall of the acetabulum to the tip to the trochanter, and the vertical limb is from the top of the trochanter to the inferior part of the neck. So that will give us two triangle flaps of capsule. I use the same approach for hemiarthroplasty as well as total hip replacement. In hemiarthroplasty, the vertical limb towards the acetabulum can be less because we don't need to expose the acetabulum that much. Whereas in a total hip replacement, to get a better exposure, we may have to extend the limbs a little bit more. Now, in a case, once we actually get the capsule incised, if we rotate the leg externally in case of a fracture neck of femur, excess neck can be osteotomized and the head can be removed with a corkscrew. Whereas if it is a total hip replacement, once the capsule is incised, flexion extension adduction will flexion adduction external rotation will deliver the head out of the joint, and we can use the corresponding template to do the osteotomy of the neck where we want. Now, that will expose the acetabulum. Here you can see in a case of hemi, the acetabulum is minimum exposure is enough, where just enough to clean, to get rid of any bony fragments out of the acetabulum. Whereas in case of total hip replacement, we need almost 360 degrees exposure of the acetabulum, which can be achieved with the appropriate placement of the retractors and Homan's retractors front and back, and maybe one at the tal or below the tal. So that completes the exposure in this anterolateral approach. And now we will go ahead with the appropriate procedure, either hemiarthroplasty or a total replacement, placement of the acetabular cup and placement of the shaft, everything is done. So once the hip is reduced, now what to do? Now comes the part of the closure of the wound. Now the initial two triangle flaps of capsule which we exposed, we can hold them with the Alice forceps or cockers, and then first close the vertical part of the T limb. So here the vertical part of the T limb of the capsule is closed. Once that is sutured, then the horizontal part which is there here can be sutured, because while cutting the capsule, we leave about a centimeter of the capsule attached still to the greater trochanter. So that is used to close the horizontal part of the T incision. That will give a watertight closure of one of the strongest layer in the hip, which is the capsule. That will give excellent stability. At this stage, if somebody wants to manipulate the hip to dislocate, one cannot dislocate the hip unless we really tear open the sutured tissues of the capsule. Now, once the capsule is closed, now then we can get hold of the combined flap of the gluteus medius and minimus. Sometimes the minimus is very well developed and we can use additional sutures for that one. But if it is a combined flap, then we actually bring it back to where it was. So here all the tissues now they are going back to their own place. So once the combined flap of the abductor muscles gets onto the trochanter, we just suture that one with number 2 Vaquerel. Sometimes in the middle of the gluteus flap, the tendon can be thin. In that area, we can use some drill holes into the trochanter and pass transosseous sutures to get the better hold of the abductor flap onto the trochanter. Once we suture that one, you can see this is the original incision where the combined flap was elevated, and the sutured flap exactly goes and sits back into that place, and that completes the reconstruction of the abductor muscle, which will prevent any abductor lurch. Now, the salient features of this approach. Lateral position has the advantage because this approach we can do in a supine position or a lateral position, but I do in lateral position because both assistant and surgeon can visualize the surgery. In a supine position, assistant standing on the opposite side cannot really see what is happening in the wound. There is a minimal damage to the gluteus medius tendon as the elevation is from the tendinous part, and strong closure is possible with, if necessary, some drill holes. And vastus lateralis is spared, which is different from standard Hardinge approach. And only one named blood vessel is cut so that there is no major bleed here. And it's a strong capsule and the capsular sparing. Here you can see, except the bone, the head of the femur, and okay, reaming of the acetabulum, no soft tissue except the trochanteric bursa is removed. So all the tissues which were reflected to get into the hip joint are really put back. They are all put back into the suture and reapproximation. So we are not leaving any dead space here. All the tissues are going back. So when there is no dead space, the capsular fibrosis or wound fibrosis is not of a major issue. And good wash before closing will prevent the heterotopic ossification, which was described as one of the complications with the anterolateral approach. Now, the ease of going back to this wound, I'll show you. Now, this is a revision case where the previous incision was marked and we went back into the same incision for revision of the hip joint. Here you can see this one again, a well-healed facial lata, which is almost as good as the primary incision, primary approach. And again, this is the abductor flap, which was repaired at the time of original incision, which is again as good as new virgin approach. You can lift the tendon flap as in the first approach. And once we lift the abductor flap, again, this is the capsule here, which was again like new. When we repaired it, the repair took so well. So it appears that as if it was not interfered with before. Now, a single surgeon series, I reviewed a long time back, about 435 cases over a period of 10 years, all with a cemented hip replacements with 28 millimeter head. Abductor lurch was not really a concern in these cases, and there were only 2 dislocations in these 435 cases. That was in the immediate post-op period when a couple of patients got agitated due to their alcohol withdrawal, walked down to the washroom and fell there and they dislocated. Otherwise, there were no other dislocations in this single man series using this approach. And that made me convinced about the usefulness of this approach. And since then, I've been using this approach where, like I mentioned to start with, where it is necessary, I am well versed and comfortable to do the other approach, posterior approach or a channelist approach. Thank you.
Thank you so much, sir. That was an excellent talk on anterior anterolateral approach. Let us ask Dr. Ashok Raju to talk on posterior approach and then steps of THR, a video presentation. Ashok.
Give me a moment. Yes. I'm here.
Stop sharing.
Yeah, I think somebody has to stop sharing. Not.
Yeah, he has already stopped.
Yeah.
It's not coming. 1 minute. Share screen. No, I don't think so. I'm getting it.
Really? Okay.
Yeah. 1 minute. Share screen again. Yeah.
So do you have the green?
No,
Yeah.
yeah, I'm getting it now. Yes,
Okay.
sure.
Okay.
Not
Great.
coming.
Okay. Yeah.
Yeah.
It's there.
I'm going, yeah, very good morning and good afternoon also. Thank you, Srinivas and Shomasekar sir, for giving me this opportunity. I'll be going through the posterolateral approach, which is, I'm going to show you a video how to go about it in a total hip arthroplasty. The main thing is that you master one approach in which you are trained. That is very important. And second thing, as Dr. Somashekar sir was saying, you should know the other approaches also, because if you have to, if you might need these additional approaches in difficult cases. So going ahead, there are a lot of people who think that the new direct anterior approach is gaining importance in view of saying that it is a daycare surgery, and most probably posterior approach, you have to go through a lot of you're cutting through a lot of muscles, and at the same time you have a higher dislocation rate. But if you are thorough in your posterior approach, and you know how to suture back your capsule and short external rotators, I think the incidence is very low. So going through the approach, the most important thing, as mentioned by Dr. Mahesh, give me a moment. Most important is positioning of your hip. That is very important. This is done through a lateral position. Very important is your posterior stability and your anterior clamps, which should not allow the hip or the body to, or the pelvis to toggle or rotate. That will make your life horrible if the patient moves. So putting your clamps anterior and posterior to achieve stability is very important. And second thing, if you look at it, I should be able to get, uh, give me a moment, I should be able to move my hip pretty well. The clamp should not come in, at least 90 degrees of flexion and adduction should be possible, and the clamp should not come in between. So this is the position I generally keep. I do not keep any pillows in between. I keep, so I do not this, and I keep the, a lot of people will keep a little bit of more flexion, but I do not do that. I keep a little bit extended like this, and I have marked my trochanter in this way. And if you look at it, that is the trochanter, that is the shaft, and that is the classical posterior approach or the Moore's approach, but I tend to give my incision more straight. My incision is equal on both sides. On the femoral sides is around 5 to 7 and proximally around 5 to 7. That is how I do. I make a incision along my mark, then I come down. I cut the tensor fascia iliotibial band, ITB. That is the constant bleeders what I get when I cut the TB. Then I split my gluteus maximus muscle and retract the posterior flap. I keep a Charlie to expose. That is the vastus lateralis. That is the gluteus maximus tendon. That is the bursa. I cut through the bursa and then try to identify the posterior border of the gluteus medius muscle. That is the posterior border. I will try to identify it and go under the gluteus medius and the minimus. Once I have gone underneath the gluteus medius, I will keep my retractor or spike around it to identify the piriformis tendon. So those are the short, that is the minimus, and that tendon shiny part is the piriformis tendon. I would erase it from the minimus, then I would cut the gluteus maximus tendon insertion. Very important, you have to be a little careful at this point because you might come across the first perforator. Then as a whole, I erase both the short external rotators as well as the capsule from the trochanter. Then I take another cut along the superior border of the piriformis and go up to its attachment and take it as an L flap, as a single large flap. Head is exposed, and then I flex and internally rotate so that my hip gets, or the femoral head gets dislocated. Once the head is dislocated, I would like to release my inferior and a little bit of anterior capsule through this. I take a or capsular scissors and cut it so that my internal rotation becomes more easy. I get back my head back into it, and then I use a Bose stitch. I was trained under Dr. Bose, so I'm familiar with this stitch for my limb length discrepancy, how much length I have to get back or how much I have to maintain. I also mark a point at the level of the lesser trochanter, one point, the other point at the level of the tip of the trochanter, it, and another point at the center of the femoral head. So I measure between the tip of the trochanter to the head and from the lesser trochanter to the center of the head. So this gives me an idea of how much I have to get back post-operatively. Then I take the rasp as a template to cut my neck. The neck cut is made in such a way that either it is straight or less of posterior, more of anterior is cut so that I maintain my anteversion in the femur. The cut is made in the neck and the head is extracted. I would like to look at the anteversion of the femur by internally rotating. Once the femoral neck becomes straight, that is how I know that this much of anteversion is there on the femoral neck. Then I would get my femur anteriorly by putting a spike on the anterior column of the acetabulum, abduct the limb, and externally rotate so that it goes more anteriorly to the acetabulum. This gives me a 360-degree view of the acetabulum. Then I put a pin in the ischial tuberosity so that the posterior capsule is retracted and the sciatic nerve is protected. Then I put another spike under the tal. So that is the tal, which gives me an idea about inclination and anteversion. Once I've exposed the acetabulum 360 degrees, I would like to remove the pulvinar or the fat pad so that I can visualize my true acetabulum. So that gives me a guide on how much depth I have to go. Then that is the labrum. I would take my cautery and remove the labrum 360 degrees to visualize my bony acetabulum. Once I have a 360-degree view of the acetabulum, then I would do a straight reaming, then reaming inclination to get the view how much of anteversion. So once I have done that and then trialing, I see that I am 5 millimeters inside the inner border of the tal, and that gives me a good and almost parallel to the tal, so that gives me a correct inclination and anteversion of the acetabulum. But not every time you can take tal as your guide. You might need to take other bony landmarks as your guide also in some difficult cases. Once that acetabulum is done, then I come to femur preparation. I take a box cut to lateralize my entry. Then I find the center of the femoral canal. Then I start broaching. I'll be parallel to the neck as far as possible. If required, a little more, do a calca reaming. Once I have tried, then I get my limb concepts very correct. I used the Bose technique, so I've got back my limb length. Once trialing is done and I have kept my implants, Then after the end of the implanting, I would suture back the capsule as well as suture back the short external rotators through Ranavel technique. So I've taken one stitch in the piriformis, one stitch in the quadratus femoris, as well as the capsule at that level. I've made 2 holes into the trochanter. Through a cobbler stitch, I would get back my sutures, what I've sutured through the short external rotators, and then I tie them tightly. During this, I would keep my hip in abduction and external rotation. So that gives me a good approximation of my capsule and short external rotators in the trochanter. And finally, I will close the glutamax tendon as well as the ITB and the rest of the tissue in with a drain. Thank you.
Thank you so much, Ashok. That was
Yeah.
a wonderful video. So without any delay, let us go on to the panel discussion. We have got half an hour to go. Let me share my screen. Yeah. So here is a 21-year-old childhood infection. Doubtful, not a clear history at that time, but started to have pain for the last 18 months. So I just want to, since he is just 21 years, want to know from the panel whether you choose cemented, uncemented, and what is the preferred articulation in this particular scenario. Let us start with Krishna Kiran.
It's a Choi type 2 septic arthritis where the hip is located. Uh, the, the disability warrants surgery, then it will be an uncemented in my hands. So I will choose an uncemented cup, an uncemented stem. Keep a cone Wagner or an SROM type of device handy because there is a significant discrepancy in the abductor length and the neck length. So we're dealing with a short offset type of situation. So I'll keep an SROM or a cone Wagner as a standby and do a ceramic on cross-linked polyethylene because the complex primary. So I'll do a ceramic ball on a highly cross-linked polyethylene.
Okay, when do you choose ceramic on ceramic, Dr. Krishna?
When you have a straightforward hip, when there is a AVN or when there is no acetabular abnormality, if you have a displaced or a deformed dysplastic type of situation or a post-septic, post-acetabular fracture or a complex thing, then we are not tending to do ceramic because you have issues with getting it right. But if you are able to position the component very well in this case, then there's no harm in putting ceramic. I would personally use a ceramic on cross-linked poly.
Okay, it's an intraoperative decision, right?
For me, it's a pre-operative decision because if I have an AVN case, I will, and the patient is less than 50, I will do a ceramic. But if it is some complex hip with a childhood pathology or a dysplasia or post-acetabular fracture where the anatomy is not exactly like the other side, then I would refrain from using a hard-on hard bearing.
Nice. So any other different views, other panelists?
Let me chime in here.
Yeah, please.
I would not use ceramic on ceramic. At least in my practice, there's absolutely no role for ceramic on ceramic with highly cross-linked poly being so well. So I can't think of a single reason to use ceramic on ceramic, to be honest, today with highly cross-linked poly being so good. Because you have somewhere between 4 to 15% incidence of squeaking, and especially in a young person, if that person squeaks, that's going to be a big problem. So, I mean, it's not a bad bearing from a wear perspective, but I would not want to take that risk. So I would probably, for this guy, I would uncemented acetabulum. Probably my standard stem. Actually, I don't think I would even need a SRAM or restoration modular type stem here, because this person has low offset, the leg length is short, so you need to restore that. So pre-op templating might help over here, but majority of the time I'm able to figure out what my leg length will be intraoperatively by doing an intraop X-ray. This is a scenario where I would think about getting an X-ray intraoperatively. And I do that 100% of the time. I mean, our setup permits us to get an intraop X-ray, and I would highly recommend one who does the hip to position the components and get the offset properly to do an intraop X-ray. So in my case, in my hands, this guy would probably get a standard acetabular component. I would make sure that I'm not over reaming the acetabulum, as opposed to going medially down to the floor of the acetabulum, or just concentrically ream it till I get the bleeding bone, so that I'm not taking away too much bone, respecting that this person might need future surgery. I would fix the cup with 2 screws, because you never are 100% sure it's well fixed or if there's a crack behind the cup. On the femur side, I would probably do a single tapered stem, because it probably takes out the least amount of bone in the proximal femur, and it's easier to revise it if there's a problem there. And I would use a ceramic head and a dual mobility articulation in this case.
Okay, so do you? Yeah, please.
No, you
one
are
question
asking. You
before
go
that.
ahead. Yeah.
Do you use dual mobility for all the hips, or in this particular case you want to use dual mobility, Dr.
In
Sridhar?
the majority of the cases, I do dual mobility bearing. In most of there will be some scenarios where I won't use dual mobility, where biomechanics of the hip come into play. So here's where you need to know the system. The cups that you use and the dual mobility bearing does not start until the cup size is 46 millimeters. And for 46 and 48 millimeter, the inner bearing surface is 22 millimeters. So there are some patients who have low offset hips. In that case, if you're using a stem that's a fixed size and you can go to a minus head with a 22 head, in that case, I would use just ceramic on poly. But if I can use a dual mobility, I will use a dual mobility. I don't see a reason not to.
Okay, thank you. Dr. Rajkumar, please.
Yeah, I accept both the speakers, Kiran and Shekhar. But my points here is you can use both ceramic on ceramic and ceramic on highly cross-linked poly. But my preference will be a ceramic on highly cross-linked poly in this. And the second thing is, here the cup, he's only 21 and the acetabulum is smaller, so you might be well prepared with a smaller cup as well. So that is the reason why Kiran has said that ceramic on ceramic will give an advantage of using a little bigger head. But that is the surgeon's choice, but mine is an highly cross-link. But the stem side, yes, the a single wedge or a double wedge like a summit, whatever it is, it should be a little low offset stem. Here, you cannot use a higher offset stem. A corail will be a little difficult situation here. But one thing I would like to contradict was the use of dual mobility in this situation. Definitely, I will not advocate, sorry to contradict this, but I will not use a dual mobility. See, having said that, I even in Dr. Shekhar's Sridhar's talk about the usage of dual mobility, I wanted to have a small discussion, because the long-term results of dual mobility are not yet available, and there are a lot of modularity involved in dual mobility. So there is even a article in JOA published in 2018, which has already mentioned about corrosion levels, ion levels in the blood, and fretting corrosion, and because of the modularity involved in that. So for a 21-year-old, definitely he will require at least 2 more surgeries down the lane, and we don't want to increase the chance of any wear possibilities in this age, unless otherwise dual mobility is indicated. So current situation, what my take will be, if you are using a dual mobility, we have to be very strict with the indications. I will not use a dual mobility without a proper indications. That is my one point here.
Right. So let us
That is
go.
fair enough. You don't have to use the dual mobility here. I'm not talking about that. You should absolutely use dual mobility here. I was just stating my preference here.
Yeah.
The data that you said on dual mobility goes both ways too, Raj. The reason being, if you're thinking about, if you're a posty approach guy, you're thinking about somebody who's young, whom you're doing a toe lip and a lifetime of maybe 60, 70 years where he's going to do crazy things and hopefully, and more than likely, God forbid, puts that hip at a high incidence of dislocation. For an anterior approach surgeon, no question, you can anterior or anterolateral surgeon. I think you can go with a regular head. For a posterior surgeon, there's enough data out there that a larger bearing surface would decrease the incidence of dislocation. Now, you're talking about the wear characteristic. There's also an issue of bigger head causing wear at the trunnion and causing problems with the trunnionitis in a younger guy. So there's an advantage to using a smaller inner bearing surface. A majority of those dual mobilities that you're talking about that have problem with wear comes from the fact that you're doing an uncemented cup and you're under reaming and putting under reaming by 1 to 2 millimeters and impacting the cup in. So what will happen is, as you said in your talk, the elasticity of the bone expands and contracts. And so the cup becomes ever so slightly smaller. So when you're putting this metal insert into a metal cup, which has been slightly modified by the elasticity of the bone, the cup, sometimes the liner doesn't lock in properly. As long as you take good care of locking it in a dry condition, it should not be a problem. Again, who knows what will happen in 20, 25 years. All the ceramic heads could break too. So, we don't have that long a track record for Delta ceramic either.
Yeah. So let's move on with
Srinivas, there is one more concern with using a dual mobility in a young patient. There is a risk of intraprosthetic dislocation, which happens in the between 8 and 10 years. So although the X3 poly may be good and the wear rates may not be as high, you are still putting the patient at a higher risk for volumetric wear. So at least in India, we are not recommending the use of MDM cups for everybody. It has a specific role in patients with neuromuscular issues, patients who are at high risk for dislocation. This patient is a no-no for a MDM in our hands, definitely not.
Okay, this is what was done, and it's a ceramic on ceramic. Comments on this?
Nicely done.
Nicely, well done.
Yeah. So for young patients, the consensus is uncemented hip arthroplasty whenever it is suitable, and bearing choice, you would prefer ceramic on cross-linked poly.
In a patient with a deformed acetabulum, we've got 15-year outcomes on ceramic. I have a personal series of 160 hips where I have not seen a single squeaking. So the squeaking is a problem with Trident. It has got a role, but definitely I would agree with Sridhar. Bearing choice in average hands is ceramic on cross-linked poly, modern day. Yeah.
Thank you so much. Let us move on with next case. So not this one. This is 14. Yeah. So here is a 54-year-old male, pain both hips, diagnosed. I don't have the what do you say? MRI pictures. It was a typical AVN, and for which I myself did core decompression. And towards left side is persisted to have pain, which was beyond for more than 4.5 months. So that is after 12 weeks of X-ray, severe pain on left side, and blood workup is normal. What would you do? Let us choose Ashok.
Yeah, I think your head is in this X-ray, at least the lower part, I think there's a collapse of the head, and pain is one of the indicators. And if your MRI is showing, I think more than 30% of involvement of the dome or the weight-bearing part of the head, I think the choice would be to do a total hip arthroplasty.
Okay.
My choice, I'm more of an uncemented guy, so I will do a uncemented. And if I get a cup which is around 52, which accommodates larger head, 36, I would do a ceramic on ceramic because he's a young guy. Otherwise, I would prefer to do, my choice also can be a ceramic on poly.
Okay. So do you change your opinion during surgery, intraoperative, anytime?
Yeah, my placement of my cup is the main thing. Coplanarity is one more thing which I would look at before I really look into hard on hard, that ceramic on ceramic. If I get
Okay.
all these things correct, then only I will do. If things are not in my favor of that, yes, I would convert into a ceramic on poly.
Yeah. Any other takes? So let me just go further. So I have done the same thing, total hip arthroplasty on left side, and so he was operated for core decompression in the first instance itself. So the thing is uncemented on both the sides, and then ceramic on ceramic in this case, and sorry, ceramic on cross-linked in this case. And 2 years post-op, he fell down again onto the right side. He has got a trochanteric fracture with avian and secondary arthritis.
Srinivas,
Yeah.
just a quick question.
Please.
Do you do routinely core decompression now?
Yeah, I do. I
Okay.
offer them surgery, although the surgical
What
results I'll
stage?
explain.
In what stage
So,
do you do?
Stage 1 and 2.
Okay. How much of
Even in
results,
this
say,
case,
like,
in the initial stage, both the sides it was stage 1 and 2. Yeah, please.
okay, but you did a core decompression and left side post core decompression. When was the THR done?
It was almost after 6 months.
In 6 months time. So
Yeah.
do you advocate, do you justify that whether a core decompression was has done anything to this patient? 6 months is really quite short duration.
Agree, but
Just
on
for a
this side it
discussion
has
sake.
lost it. Agree.
No,
Fully agree.
For a discussion sake, I also wanted to hear from the faculty, other panelists, whether they still routinely do a core decompression, because we have to be very clear whether that core decompression itself was a part of the treatment. So right. I know that now we have gone to the next stage on the right side, just to discuss a point about this core decompression. Either we can discuss now
very
or
interesting
after
question.
This X-ray.
Yeah, other faculty, who all wants to do core decompression in type 1 and 2?
Yes, Srinivas, Satish here.
Srinivas.
Yeah, sir, please.
Yeah, I do core decompression. I offer it. It is a simple surgery. It's very often you see that it postpones the surgery for for some time, and it doesn't cost much. So I mean, I do core decompression routinely in stage 1 and stage 2.
Yeah, Srinivas.
Okay. Sir, Somsekhar sir.
Yeah, I have actually patients more than 10 years post core decompression. The problem is when somebody comes, they may come on one side 3 and 4 and the other side 1 and 2. And when we advise core decompression for the 1 and 2, they say that, okay, why don't you do something to this one? And sometimes we may end up doing core decompression for 3 also on the other side, even though we don't recommend that. Ultimately, that may go for a hip replacement, but the one which patient comes asymptomatic, which we diagnose as 1 and 2, where we had actually core decompression with alendronate treatment for minimum 6 months, sometimes in 1 year. Those are the patients, those hips actually for me survived more than 5 to 6 years, even some case 2-3 cases up to 10 years, with still not needing any hip replacement.
Great, sir. What about Mithil?
Can I?
Yeah. Krishna Kiran, please.
I also routinely do core decompression for stage 1 and 2, and thankfully till now I've got a quite a long period of time before I really converted THR, maybe an average of 1.5 to 2 years. And patients usually are more accepting for core decompression. It is like, okay, like if this surgery works out well and fine, and if it doesn't work out, then we'll go ahead with THR. So patients are usually more acceptable for core decompression in stage 1 and 2. At least in my hands, we are having fair enough results.
Right.
Uh,
Krishna
uh,
Kiran, please.
yeah. So we looked at 40 patients and we published our data in radiology journal, it's an index journal. So we looked at pre-core decompression MRI and we looked at post-core decompression MRI at 1 year. And we delineated certain factors which are favorable for success of core decompression. And if you have a lesion which is medially located, so you have three areas. You can have medial, central, or laterally located lesion. You can have the size of the lesion. It's more than 50%, between 30 and 50, and less than 30%. So uniformly, we found that if we had a lesion which was laterally located, weight-bearing dome, and which was larger than 50%, then the failure rate was very high because the core decompression itself led to the collapse. So the collapse happened because of the core decompression. So, and even if you look at literature, isolated core decompression has no role, because if you have bone marrow edema with a 30% lesion, 3-4 months down the line, once the edema subsides, that patient becomes all right anyway. It's not the core decompression which made the patient do well. But if you had a bigger lesion and you just did a core decompression, big core, and left it like that, the patient would collapse faster than what happened. So I have personally patients 10, 8, 9 years down the line with core decompression who have done well. But that single patient will not justify a core decompression. So when we looked at 40 patients, we had a 10% failure rate overall. But if we look at the subcategory of patients with a 50% or more lesion, laterally located lesions based on the MR classification, the failure rate was much higher. It was almost 30 to 35%. So it doesn't justify. So if you can still do a core decompression, but add a structural graft if you want to, and also pre-qualify which patients you want to do with a bone marrow edema, with a lesion which is less than 50%, more medially located lesion. So I think there is a need to sub-qualify where you want to do the coding.
Okay.
Yeah, I think the most.
What about Dr. Sridhar?
So Krishna Kiran, let me ask you one question. Those people with less than 50% head involvement and medial lesions, do you think those people would have progressed to arthritis even if you didn't do the core decompression?
Yeah, absolutely. So that is the point. So when we were doing this study, we were not sure. So we were just doing core decompression. And once we looked at our data, we thought there's no role for core decompression at all in our hands. So we stopped doing core decompression.
Yeah, just to add one more point. Sridhar, please go ahead. Sorry.
Kind of my experience too. I used to do a bunch of core decompressions. Lately, I'm not doing as much.
Yeah.
Because the majority of the time when somebody comes in with AVN and pain, they have some kind of collapse somewhere. So you got to closely look at if the head has collapsed or not, getting the MRI scan, looking at the sphericity of the head, things like that. It may be difficult to find collapse. And as KK said, I definitely agree that if you do core decompression, you got to put some kind of mechanical support in there. So typically I tend to put something like I decompress the head. I tend to put some kind of hydroset or some kind of calcium phosphate supplement so that my decompression itself won't cause additional collapse. I have to say my experience has been mixed. I mean, people with sclerotic lesions without much changes seem to have done well. So I'm more inclined to doing core decompression in a younger person than an older person. Like if somebody comes in at 50, 54 with avascular necrosis, one side has collapsed, that the patient's telling you something. Natural history is going to progress that way. So I don't see a big reason to do the core decompression on the other side. So I do core decompression for altering the natural history. I do core decompression for symptom. Some people have symptoms from increased pressure in the head, and that's one of the reasons why I do it.
Yeah, I agree
This
with that.
particular case is a typical example. In this left side, he has got severe pain, although both were in stage 1 initially, but right side, he didn't have symptoms for this long. At least he is managing. I won't say, because he's turned up only after 2 years, right? On the right side.
No, as Sridhar rightly
Because he
pointed
had
out,
a fracture, he came.
Correct. The pain is because of the fracture. So you ride out 3 months. A lot of them will have bad looking x-rays, but they'll manage for several years till secondary osteoarthritis sets in.
Yeah.
So, and when we operate on these fractures, you have a delaminated cartilage which just pulls off from the thing, which again takes the sense of doing a core decompression out from my mind, because your cartilage just peels off from the underlying avascular bone. So even if you make a drill hole and then support it, it's very unlikely that delamination will be prevented, because it's a blind procedure. we don't know exactly where we are doing that core, and then so I have my reservations. I've stopped doing core decompression for a while now.
Krishna Kiran, quick question from, you said about 70%, 30-40% and it's not working. The other 70% it worked. How long did those 70% of the people, I mean, how long they were symptom free?
Dr. Satish, the point Sridhar was making, the natural course of avian itself, if you leave them alone, they will work 60-70%. I don't think it's a core decompression which led them to which has worked. So that we have given. So if you have a medially located lesion which is smaller, on an MRI, there is no need to do core decompression any which way. So those are the ones which are likely to be successful, and they'll be the flag bearers of your procedure. But if you actually do it for the bone marrow edema, which is an indicator of impending collapse, it will collapse earlier. So if you had to collapse at 1 year, it will collapse at 6 months because you've done a core decompression. That's been our own experience, and we've published that.
Yeah. Right. So here now the question is, he has got a trochanteric fracture with arthritis. Now, so my question is, what kind of implant we have to choose in terms of, especially on femoral side. So, Krishna Kiran again.
Yeah, you have two options here. You can do a distally fixing device like a Wagner, and do a THR to start with. But if you can wire the proximal part together, then you can do a sleeve proximally and then do a proximally fixing device like an SROM as well. But I would think more of a Wagner type device in my hand than an SROM for this.
Okay. Any role of cemented in this?
No.
Okay. Any other takes on this?
No, this is like he's only 54-year-old and already got a fracture line extending all the way below the lesser trochanter. So the cemented process will be a real catastrophe here. That is what I will suggest. So I will definitely, as Kiran said, my point here is distal loading stem, like a Wagner 190 size. The smallest Wagner 190 would be the best option.
Okay. So the same thing was done in here. Wagner was used. Wagner stem.
Yes, Sridhar needs to unmute himself. He needs to say something.
Yeah.
Yeah.
So I had a point to make. Go back to the previous X-ray.
Yes.
In this case, when you're seeing this patient, you're thinking about a few things. Whenever you're doing intertroch fracture and doing a toe lip, there are a couple of issues. The morbidity and mortality of doing a toe lip in an intertroch fracture is high. Number two is the problem with handling the trochanter and the abductors. That's going to be an issue here too. So there is a role in this scenario, even though this patient is headed towards a toe lip down the line, to get that simple intertroch fracture fixed with maybe a 2-hole DHS and go down the line once the trochanters are healed, to make the procedure a lot easier and save the bone and maybe potentially use your prime component.
Yeah.
And later, once he is symptomatic, go back and do the total lip later.
I don't know how accepting an Indian patient would be for that treatment, but over here, if the patient showed up in my practice here, I would probably just do a 2-hole simple DHS. It's a simple fracture, get it fixed, and down the line, if it becomes symptomatic, you can go in and take that out. It won't be a big problem converting that because anatomy and geometry of the proximal femur is much well maintained.
Agree.
And now in mind, this will be a relative indication for a dual mobility socket as well, because we're dealing with an abductor mechanism.
Yes.
Problematic, So dual mobility here, yeah.
Great. So the comments about this fixation. So it was a Wagner stem again.
Is that a Wagner stem, Srinivas?
Yeah, it's Wagner. Yeah. It was a Wagner stem.
Looks like a continuum cup with a Wagner stem.
Yeah. So that is after a year of follow-up, actually.
Yeah.
So the fracture has healed. He's doing well. I'll take you through some other. Yeah. So a 25-year-old female, previously operated for some trochanteric fracture. Don't have the details. and the implant was also removed. Now she is very painful, not able to walk with this kind of a picture.
Is there fracture? Is there any non-union there in the fracture?
I don't think so, sir.
Okay.
It's an IT fracture.
So must be an IT or some kind of a unstable or subtrochanteric kind of a fracture which was fixed with, because it was a DCS, not DHS. Don't have the previous X-rays.
Yeah.
Other side had a head fracture which was fixed.
Yeah. So
no infection.
No infection.
I think I would do a lateral view and get a CT on this patient. Yeah.
Yeah. Okay.
LT is almost in the joint.
Yeah, agree. So lateral view also I don't have at this point of time because it was done in haste in the night preparation.
Oh,
but it was done.
yeah. So these cases we must look at how the lateral view looks like, because operated previously trauma.
Yes.
And also if you look at the line of the femoral shaft and the tip of the trochanter, the line of the femoral shaft is almost beyond the tip of the trochanter. So that could be because of the rotational alignment of the limb. But also we must keep in mind whether we need to do a trochanteric flip or a transtrochanteric type of approach for this thing to just to line your canal up. Sometimes your stem will go into too much of varus.
Okay.
So and then you need to have modular implants, because sometimes it can be malunited in different version. So you will either have to have there are three options. You can have an SROM, you can have a cone Wagner, or a cemented stem. So three options. 25-year-old girl. So I would keep SROM and cone Wagner as a standby for this patient.
Okay. Okay. Rajkumar.
Yeah. I was about to mention the same thing. The only thing is, as I said in my talk also here, the lateral view is absolutely necessary because the bone is sclerosed very much, and you have to make sure that lateral view is there. And then my choice is here. If you see the neck shaft angle is very low, so it's like almost like a Coxa Vera type of this thing. So you have to have your offset correct. So if at all, if you are using, you might need a lateralized stem or a little high offset stem. A small cup, 25-year-old female, small, younger age, very small cup. So small bantam cups, and then an SROM system, I think will be the best option to go with.
One doubt, how stiff was this hip? Did you plan subtrochanteric osteotomy, maybe to bring down? Was it very stiff? Were you able
to? Do you mean to say only osteotomy you want to do, or?
No.
I didn't get your point.
The hip looks stiff because if you can see it is migrated proximally.
Yeah.
So that maybe you had to prepare for a subtrocostotomy also for the.
Okay. Yeah. So that's Sridhar.
I would not make this too complex. In general, try to keep this thing simple. That's my philosophy here. I know we suggested about high offset stem. That depends on the opposite hip. You got to template the opposite hip to see what kind of stem will fit in there, not this hip, because you're trying to lengthen this hip up a little bit too. This hip is short. So the way you would lengthen this hip is by decreasing the offset. Otherwise, the soft tissues will be extremely tight. So I'm not sure you really need a high offset unless you template on the other side and see the soft tissues being, the other side needing a high offset stem. I would personally choose, a cone Wagner type stem, a tapered fluted modular stem, which would allow me to have control over the length version and make the surgery a lot easier in this type of scenario. The difference between tapered fluted modular and SROM stem is SROM stem's got so many trays, it's so painful to do that surgery more than tapered fluted modular stem.
So any role of cemented processes in this?
25, again, I I would, again, I have a bias towards uncemented. Obviously, you can do a cemented stem too here, no question about it. It'll give you infinite modularity. One thing I would want against cemented stem here is that proximal femur geometry is altered here.
Yeah.
Not have good enough bone for cement into cement percolation through the cancellous bone. And also the geometry may not be that great for cemented stem here.
Yeah.
Also, there is no role of subtrochanteric osteotomy for this because your lesser trochanter is below the level of the teardrop. So that's an indicator. So if your lesser trochanter has gone up and there is subtrochanteric shortening, then you do subtrochanteric shortening. This is a supratrochanteric, if at all, because your trochanter is a little bit overgrown. So you do something here. You have to do a trochanteric osteotomy if at all needed. If not required, then I would agree with Sridhar. The Kohn-Wagner is a good choice here. I would not do a cemented personally in this particular.
And also the head is inside the acetabulum, so you definitely don't need to do a subtrochanteric.
Definitely no. Yeah, definitely no.
Right. Would any of you keep cement
in the offset?
Sorry.
Sorry. This is what was done. So I've used the SROM in this case, but the medial bone prominence looks too much in this case. Although it was not impinging, checked in on the throughout the range of movement.
That is because of the previous surgery and then altered anatomy. So I think that's not a problem at all.
Yeah. So and another issue in this particular case, because of this narrow canal, Wagner stem, is it really possible to pass Wagner stem?
You have Kohn-Wagner. It's not Wagner. Kohn-Wagner is different. Yeah.
So I was about to say that a tapered fluted modular stem won't be any smaller than 14 millimeters. The smallest fluted modular stem is 14 millimeter, but the Kohn-Wagner that he was talking about, the dog stems that you can use for DDH that Zimmer makes, that's something potentially use here. A small bantam AML stem is another option too.
And also, Sridhar, I heard every time you mention about Wagner, you are mentioning about modular, but in India, we don't have the modular Wagner. We have the monoblock.
Yeah, you don't have the link type stem?
That we have, but Wagner, we don't have the modular one. We have only the monoblock.
Okay.
No, but I think Sridhar was mentioning about the modular fluted stem, not modular Wagner. So I think we don't use mid-stem modularity here, Sridhar, because we are worried about the corrosion and fracture and stuff like that. So where we can manage with a monoblock stem, we would just do a monoblock stem. So it's very rare for us to use any mid-stem modularity at this point in time. So only modularity we are using here is a stem and sleeve construct, the SROM. So we still watch the yeah.
Dr. Srinivas, how tight was the soft tissue when you operated? Which approach you went for this?
The posterior approach, same posterolateral, like Ashok has shown, more or less same kind of an approach. So it was not that tight.
Go back to X-ray street.
Pre-op X-ray.
So, shall I?
Yeah, the biggest thing in a failed intertrope fracture, you got to remember about a few things. Number one is that acetabulum is porotic, usually. So be careful reaming the acetabulum. Sometimes, even though you don't anticipate problems there, you can just go through the acetabulum if you're aggressively reaming it. So be careful when you're reaming the acetabulum and be careful doing that. Second issue is that if there's hardware in there, you want to dislocate the hip, relocate it before you take the hardware out. The third thing you want to remember is that the proximal femur geometry is altered, so figure out a stem that you're going to use there. Fourth thing you want to know is that there's usually HO around the hip joint, with extra bone healing that can lead to bone-on-bone impingement. And be careful with assessing the stability. You may have to chop off some of the bone around the proximal femur, and if you do so, you may want to give some HO prophylaxis post-op.
So thank you so much for contributions from all the faculty, because it's already 12:40, nearing 12:40. Thank you so much for your time, even on Sunday. And special thanks to Dr. Sridhar. Even during this odd time for you, you're still active and enthusiastic enough to answer all the questions. Thanks so much for you. And I'd request Johnson people to conclude it.
Yes, sir.
Yeah, Kishore.
Yeah, thank you so much, sir. Actually, it's my privilege to have been asked to propose a vote of thanks on this occasion. In fact, so one of the wonderful program on behalf of Hanson Pharmaceuticals, I'm extending a very hearty vote of thanks to all the doctors who supported this program with their presence, even on Sunday, especially, sir. And special thanks to all the panelists, majorly. That's very important for us. And even I'd like to mention even Twin City Orthopedic Society for giving us this opportunity for hosting this program. And special thanks to Dr. Kasha sir and Dr. Somsekhar Reddy sir for giving us this opportunity. Thank you so much, doctors and panelists. Thanks a lot, sir.
Thank you all.
And I also thankful to Mr. Lokesh, who has supported from the technical side and background for ensuring a smooth running of this program. And thanks to all the viewers also, sir.
Thank you. Bye.
Sign off.